webinar from PP Paraboy and AstraZeneca with the topic of DNA damage response in breast cancer. Let me introduce myself. My name is Alif, and I would be the MC or host for today's webinar. Before we start, I would like to explain today's webinar agenda. First, there will be an opening remarks from the president of PP Praboy, Dr. Walter Gautama, and then we will proceed the main agenda from two of our speakers, Ahmad Ruslan Handoyo, PhD, and Dr. Gita Kadayaprat. That will be guided by Dr. Samuel as our moderator. And for the last session, there will be a panel discussion for question and answer. For the opening remarks, please welcome Dr. Walter. Thank you, Dr. Walter. The stage is yours. Thank you.
Thank you, Dr. Alif. Good morning, college. First of all, I'd like to greet for moderator, Dr. Samuel, and our two panelists, Dr. Sonar and Dr. Ramadan. And let me extend my warmest welcome for two speakers, Dr. Ahmad Rusdan Handoyo Utomo and Dr. Gita Kadayaprat from, Director Breast Surgical Oncology and Oncoplastic, Max Institute of Cancer Care, Max Healthcare, Delhi, India. That's right, Dr. Gita?
Yes, you pronounced my name very correctly.
Okay. Welcome to the Oncology Expert Sharing Forum. The title today is DNA damage response in breast cancer. Perhaps this is not something new science for the past few years. The studies for breast cancer have focused more and more on cellular pathway. However, for us, clinical, we are not quite familiar with the subject. Some of us who took the doctoral degrees may be familiar with it, but not for most of us who work every day in clinical and operating theater. But if we would like to understand more on cancer therapy, we must familiarize ourselves with the subject. We know that every cell intrinsically has DNA damage response that would give the cell itself repair ability or itself kill ability. But in cancer cells, scientists see something different. DNA damage response in cancer cell is altered so that the self-repair ability becomes unlimited and prevent the apoptosis. And they are learning more and more about various pathways involved in DNA damage response. They learn that if we can inhibit some pathway of DNA damage response, then we can stop the self-repair ability of cancer cells, and by combining it with the DNA damage agent, we can create more targeted therapy for cancer. That is as long as I know. Breast cancer is a cancer with the highest incidence and highest mortality rate in Indonesia. More than 60% are diagnosed with stage 3 or stage 4 breast cancer in their first visit to the doctor. We have worked together with the Ministry of Health of Republic Indonesia and many survivors. Many survivors group and non-government organizations to promote breast cancer awareness and early detection. It has been a long journey, but in the other leg of the journey, we must keep updating ourselves with more updated and more effective therapies for breast cancer. And that is why we are all here. gather together to update ourselves with new information as knowledge, to equip ourselves with enough ammunition in our embark to help patients with cancers. I wish and hope a successful and fruitful transfer of knowledge and lively discussion. Hope everybody can benefit much from this Oncology Expert Sharing Forum. Thank you.
Okay, thank you, Dr. Walter, for the opening remarks. And let us proceed to our main event for Dr. Samuel Haryono as our moderator. The time is yours. Thank you.
Terima kasih dan selamat pagi bagi teman-teman sejawat dan para peserta dalam webinar kali ini dengan judul DNA Damage Response in Breast Cancer. Yeah. On behalf of the Indonesian Surgical Oncology Association, I herewith welcoming you all, and especially for our distinguished guests, Dr. Gita Kadayapara, a surgical oncologist, and my best friend, my partner, Ahmad Rusdan Budoyo Utomo PhD. Halo Mas Ahmad, selamat pagi.
Pagi, Dr. Samuel. Alhamdulillah sehat, Dok.
Ya. Baik, on this beautiful Sunday morning, we'll have a relaxed and also a serious discussion about this DNA damage response. So, without further ado, I would like to have the first speaker to come up with a presentation. Dr. Gita Kadayapara, please, floor is yours. Thank you. Maybe could you, the committee could provide the curriculum vitae to present for us for the Dr. Gita. Thank you.
Should I go ahead? Are you able to see my slides?
Yes, Doctor. Very
Yeah, we
clear.
can see.
Yes, we can see.
Yes. Yeah.
Very
Thank
clear.
you so much for the invite. Thank you, Dr. Samuel. I have had the opportunity to interact with you briefly earlier on. And Indonesia and India share a lot of common ground. So, you know, your gods and our gods have common ground. And I believe Rama and, you know, when you say Bali, and, you know, I think we share the same mythological background to a large extent. And this is my first interaction, if I may say, with Indonesia. I've not had the opportunity to visit this beautiful country, but I hope in the future, when things are better, it will be possible to do that. So it's great to be interacting with, you know, a large number of surgical oncologists. And I'm really, really glad to see such a wonderful attendance on a Sunday morning, because I'm sure for surgeons, Sundays are very, very precious and it's hard to come by. And I would like to share my perspective as a surgeon, because I believe that we need to understand this. It is very, very important to understand what happens with each of our patients, because I think delivery of care is our responsibility, because I believe in Indonesia also, patients would be seen by surgeons first, possibly, you know, coming to you through gynecologist colleagues or from general practitioners, they come to you. So you have the onus of taking the patient through the entire journey. So, you know, patients can be advised several medications, several rounds of chemotherapy or targeted treatment or hormonal treatment or radiation, but eventually you are the main spoke and the patient will always come back to you for advice to find out whether what is happening with them is right, what needs to be done. So for that reason, I think we need to improve our level of awareness of the new things that keep happening in this space. And it is happening so rapidly these days. Only last week, about 4 drugs got approval for metastatic HER2 positive breast cancer. So, it's a lot about sequencing, what should be done, who can afford what. So we have the responsibility to ensure that our patient gets the best treatment, but at the same time, we have to be very cost conscious because not everybody can afford these new treatments, which are kind of expensive. But I'm sure everybody has a subset of patients who can afford this treatment. As a clinician, it is my responsibility to put everything on the table so that the patient makes that informed choice. I cannot decide, well, I am not offering this. We can't do that in these times. We have to offer what is available. And I will take you through what is happening now in advanced breast cancer, especially the ones which show the germline BRCA mutation, because that is where the intervention is. That is where the DNA repair gene has to be stopped, so that just as my previous speaker said, we have to not allow the cell to repair itself and let it die by intervening with various medications that we have. So the disclaimer is that this is being organized by AstraZeneca. And so it may contain off-label information. And I would like to go to the agenda. So this is how I would be dividing my talk. So we'll be talking about genetic counseling and testing. I think this is a pain point everywhere. So when we started off, so we were also kind of very, very reluctant to get these things done, primarily because we did not have the facility. When you don't see these things happening in your face, you just put it on the back burner. But now in the last 8 or 9 years, we've been very, very conscious about this. I work in a corporate hospital, and in our hospital, there is a large uptake. But if you look at India as a whole, I think we would match with what is happening with our South Asian counterparts. So I will talk about what is happening in India, and I would be talking then about the current treatment guidelines and options that are available in advanced breast cancer. And then I'll be talking about this relatively new kid on the block, PARP inhibitors, which are completely, it is recommended, it is accepted in ovarian cancers, but they have found a space in metastatic breast cancer. So we will be talking about BRCA in breast cancer, and we'll discuss the Olympiad trial. And just as it happens with every drug, you would start off in the metastatic setting, then come to the neoadjuvant setting, and then to the adjuvant. But this is the Olympiad trial, and I'll just leave you with this thought of the Olympiad trial. Only today I saw a little article in the New England Journal of Medicine where the PARP inhibitor in the adjuvant setting has come in. And I will also take you through some case studies that were patients in our practice, and then that will be that is how I'll conclude my talk. So let me just take you through genetic counseling and testing. Just a second here. So genetic counseling is you all know that there is a specific person for it. Earlier, we were the ones who would do it all the time. But with increasing burden on your practice, sometimes it is good to have a counselor and who provides the relevant information, because the patient wants to know what is the disease burden, what is the etiology, what kind of investigations that I need to do. And if at all I do an investigation, what are the implications and what are the therapeutic options? So basically the counselor's job is to put the information on the table and then an informed combined decision with the patient. So the BRCA testing process, I will just take you through this, the referral in patients, in healthy patients, in healthy adults and patients. So this is available, and I'm not sure how it works in your country, but it is also available over the counter, which is a little worrisome for me, because I would always take this path. And we know that it is easy to do this testing. Testing is not the problem. So you will focus on the family history, and if there is a known founder population at risk, you would subject those healthy individuals also to this testing. It can be used, it can be done on blood, or it can be done on a buccal scrape or saliva, and sometimes even infrequently on tumor samples. So if a patient is referred to an oncologist, suppose you don't have a genetic counselor, doesn't matter, but you must counsel first. Counseling is very, very important. And then talk about the testing. Whether the patient wants to get the test or not is also a choice, because there are social implications to this also. So many times my patients have said, look, I don't want to know about the test. I have a young daughter. I want to get her married off. I don't want to know whether I've got the mutation, and I'm definitely not getting my daughter tested. So what happens in the genetic counseling is that in many countries, what is happening is that there is a bottleneck because of the turnaround time due to the increased demands that are placed on the need for genetic counseling. So you may not easily get genetic counselor, a trained genetic counselor. So what is the purpose of genetic counseling? Once you understand that, then you can don that hat also till the time you have a robust genetic counseling mechanism. So what you need to educate the patient is what happens, what is the likelihood of a positive result? Not everybody would have the same kind of likelihood. So you have to differentiate if there is a population at risk who's got a foundation gene mutation, or if there is a high family risk, or if there is only one person who's got a breast cancer in the family. So you have to explain to the patient what is the likelihood of you getting a positive result, and the risks and benefits of doing the test. There are limitations to the test. We all know there is this category of results which comes back as VUS. What is the practical meaning of the result to the person who's sitting across the table and also to the other family members? And what are the risk reducing measures that you can take? So you have to explain. It can range from very, very close follow-up to the other extreme where you would be advising prophylactic surgeries. So why genetic counseling is important? So when you find a mutation, it does not necessarily mean that this person will develop cancer. That is very important to understand. And if you don't find a mutation, it does not mean that you may not develop cancer. So this is a very interesting situation, but that is where we are, because we do not know all the genetic mutations that are operational. So obviously, if you don't find a mutation, but you have a strong family history, it does not mean that you will not develop cancer. Then, of course, VUS is a huge challenge. This is variant of uncertain significance. We do not know what it means. We do not know what are the implications. Does it translate into something significant for the patient in the future? Does it have any treatment implication? We do not know. So this is where we are. So what we have to do now, so the testing is not just limited to understanding risk alone. So there is a dual purpose to the testing. One, of course, you would know what is the risk of developing cancer. Is there any preventive measure that you can take? But the important development in the last several years has been treatment decisions based on what happens when you do a genetic testing. So if you were to find a mutation, does it guide your management decision? And if it does, and it impacts your treatment, I think it makes it all the more important to undergo these tests. So when you do a genetic counseling, you would do a pre-test genetic counseling, wherein you will do a pedigree analysis. A basic pedigree analysis is very important. And how would you risk assess? So there are various models. We are all aware of the Gale model and the Claus model, but now we have moved forward because these are automatically generating algorithms there. So you have BRCA-Pro, Bodesia, Manchester, etc. And then, of course, the familial risk stratification also should happen. So you have to have an informed consent process. The patient should be completely aware of what this test would entail, what would happen if it comes back as positive or negative. Patient education about the benefits and ethical issues. The ethical issues in different countries are different, so you should be very, very cognizant of that also. The genetic counseling is done. Now the consultant, if you are the genetic counselor or if you have a specialist genetic counselor, you have to sit down with the patient again, talk to her about her result, interpret the result while she's sitting across the table, and then talk about what are the management options that are available. And then you have to support it in adjusting to the results. And of course, talk about how this result is going to affect her family, which is a very, very important consideration. So a simple pedigree chart just to show you how we would look at who is the most influenced by the presence of a cancer in the family. So if this is the proband, so the most affected are the first line. So when you say first degree relative, you're talking about the siblings, the children, and the parents. So that is what your first degree relative is. You move out a little, so the grandparents, the aunts and uncles or fathers and mothers, and the grandchildren become the second degree relatives, and also the nephew and nieces of the proband. And then if you move further away, the great aunts, the great uncles, the first cousin in the previous generation become the third degree relative. So these are certain ways in which you would denote the various characters in this pedigree chart. So this is a very constant thing, and you must make use of these symbols for making it easy to read. If I were to look at this classic BRCA pedigree, so you see this is the this is probably the proband. Okay, so if you have there are 3 children in this generation. This is the grandmother who died of ovarian cancer, and then she had 3 children, 2 girls and a boy, and one girl had breast cancer and the other had ovarian cancer. And the son did not carry the mutation because in every generation we know there is a 50% risk of passing on the mutation, and the daughter of this son developed breast cancer. So that is a very typical BRCA pedigree. So now, so I've told you that we have to discuss the results of what happens on the BRCA testing. So if there is a pathogenic mutation in BRCA1 and BRCA2, so if the index case has a high predisposition to developing cancer, we know this. And the other associated cancers should not be forgotten. It is not just about breast cancer. It could be ovary, it could be pancreas, it could be prostate, it could be melanoma. It could even be, so these are the various cancers that one should work out. And what is the therapeutic implication? So we know what are the cancers that can develop. The therapeutic implication is that there is sensitivity to platinum and PARP inhibitors for those who are a germline BRCA mutation. So the first degree relatives are, like I said, there is a 50% risk in the next generation of carrying the mutation. So if there is a benign or a BRCA-like kind of a mutation, then the variant has not been confirmed and it is not clinically relevant. That is important to convey to the patient. So there is an average risk of developing cancer, which is similar to the general population. So there is no increased risk. So these patients should undergo further investigation, find out more about the family, and possibly if the family risk is still high, then you should offer her a multi-gene testing rather than just BRCA1 and BRCA2. So if there is absence, this is a true negative. True negative meaning their risk of developing breast cancer is same as that of the general population. But however, again, if you were to go deeper into the family history evaluation, then multi-gene assays may be done because BRCA may not be the site of mutation, something else may be. So BUS is what we struggle with all the time. We do not know what is the functional implication basis VUS. And you have to keep a track of this VUS to look whether there is a reclassification in the subsequent times. The risk cannot be accurately quantified by the test alone. But again, the family history and the testing of the other affected family members may give us a clue as to what else needs to be done. So if you look at the genetic counseling scenario in India, I'm sure it is not very different from what is happening in Indonesia. In the urban cities, you may find a concentration of the genetic counselor. You move out 20 to 30 miles away from the cities, you would not find any genetic counseling at all. So there is a dearth of genetic health professionals. There is a lack of multidisciplinary care in the smaller towns. And there is a pressure on the oncologist who's already burdened with clinical work to provide genetic counseling. And of course, we have a huge population. We have different ethnicities, different languages, large geography, very difficult to reach out to everybody. But we have to find a way around this situation. The situation is not going to change, but we have to change our approach to how we reach out to these people. And that is by building multidisciplinary teams and mainstreaming the process of genetic counseling into the oncology setting. So when I say mainstreaming essentially means that bringing in the oncologist to become part of this multidisciplinary team and take part in genetic counseling as well. A good idea is to include or incorporate genetic counseling training within university curriculums and building national guidelines for genetic counseling and testing with special reference to BRCA testing and counseling, and also educating patients about the need for the testing and how the geneticist plays a role in cancer care. So you have technology now. Today, I'm able to connect with you primarily because of technology. Otherwise, getting in touch with a large population is very difficult, but with telegenetics, video consultation, telephone and telemedicine, it is possible to counsel patients and to offer them genetic testing. It is also possible to do group counseling if you have counseling the relatives, the family members, along with the person who is affected. So all this is possible because of telegenetics and remote-driven methods. So non-geneticists are also provided online courses. It is easy to do this. I see a lot of investigative, meaning investigative researchers and also investigative clinicians trying to get into these online courses and getting trained as genetic counselors. And then genetic testing, of course, can be completed at the time the patient comes in for an oncology appointment. So why do clinicians need to mainstream? Why do clinicians need to step in to counsel patients? Because you realize, as surgeons also we realize, it is the relationship that you build with the patient that is important. It is what you say that the patient will do, and not possibly, once you have primed the patient and the patient were to see a genetic consultant, that becomes easy. It becomes the task of the genetic counselor becomes easy. So your pre-existing relationship with the patient is very, very important in convincing her to be able to take the next steps. Testing turnaround time is much faster because obviously when you are talking to them, they would go in for the test earlier than later. And so the turnaround time is much faster. And you are well within your rights to discuss the treatment options. They want to hear it from you. And when you tell them what are the treatment implications, they are willing to hear you. It negates the need. So if I were to refer a patient to the genetic counselor, I don't know when she's going to get the appointment with that counselor, because as it is, he or she is overburdened. But if I were to step in, then you don't need to refer to another team, and there are fewer hospital visits for the patients, which works very well in these COVID times as well. And of course, there is a lower cost also for the patient. So who are the ones who need to be tested? There are enough guidelines out there, whether it is the NICE guidelines or the NCCN guidelines, which I believe you also follow. So important before you subject the patient to testing to take an informed consent. And the criteria can be different in different countries for various reasons, and also depends upon the differences in the mutation prevalence. So the criteria just generally includes age, family history, and personal cancer history. So this has to be recorded in your prescription when the patient comes to you in clinic for maybe a symptomatic lump, or if she just comes in for screening. So the widely accepted criteria for referral is if there is a known susceptibility gene within the family. There are 2 breast cancer primaries in a single individual. When it is a triple negative breast cancer under the age of 60, any breast cancer diagnosed under the age of 50, a single male breast cancer is also criteria for BRCA testing. Personal or family history combinations of a male breast cancer or an epithelial ovarian cancer or early onset breast cancer, pancreatic cancer, aggressive prostate cancer, bilateral breast cancer. It could be an Ashkenazi Jew because of a lot of consanguinity in this particular group. You see a lot of breast, ovarian, and pancreatic cancer. And breast and ovarian cancer in the same patient also fits into the criteria of who should get tested. So a healthcare professional may use a risk assessment criteria based on your medical society's guidelines or based on his or her own professional judgment. Then you can use a relevant scoring system like the ones that I mentioned briefly, the BRCA Pro and the Bodesia Therapeutic. The results may impact who gets tested. Testing criteria based on family history alone can lead to a miss in the proportion of BRCA mutation positive testing. So you just combine the various methods. Many patients with ovarian cancer who are BRCA mutation positive would not be tested, although this is to be less restrictive. So these are the various scoring systems that I was mentioning to you. Clause model, the clause extended is a better model. The Manchester scoring system, the BRCA Pro, Bodesia, Myriad, Therapeutic, and Cyrillic programs. These are a whole lot of scoring systems that are in existence, and you can use them to have an objective understanding as to who requires to be tested. So we know that it needs to be cheap, quick testing and all that is achievable. We need quick and simple results. At the moment, gene testing would take anywhere between 3 to 4 weeks. And it needs to be simple so that there is consistent triage into the various clinical actions that we need to take. So now when we look at what are the kind of platforms that we are using to find out the BRCA mutation, so the direct or Sanger sequencing. This is the gold standard of DNA sequencing, which was invented in 1977. It is a very reliable method of BRCA testing. It has got the potential to screen an entire region, enabling detection of all germline mutations. So that's why it's quite versatile that way. It is widely available. It has got a simple workflow. It is automatable and it defines the mutation. This is the advantage. But the disadvantage is that concurrent amplification of multiple target sequences is not possible. So you cannot target multiple sequences in this. So there is limited throughput and it has got decreased cost effectiveness if you were to compare it with the newer platforms, which is the next generation sequencing or the NGS. So what needs to be done is you have to do a quality control assessment of the sequence quality, identify the variants, and then report. This is how the Sanger sequencing works. So with next generation sequencing, this is a very good technology for BRCA testing. It has a high throughput and the cost is lesser. You get more information for less cost. So it generates huge amount of data. So the advantage, of course, is that it is, again, automated analysis. It requires very little DNA and it can run parallel in other genes. But of course, if you have to invest in it, it's a new capital cost. If you do get a positive result, to confirm it, you may have to put it through Sanger sequencing. So it has a complex workflow and dedicated data analysis and storage is required. And it has low sensitivity for insertion deletions of more than 20 base pairs. So this is how it works. You have to validate the NGS tests, do a quality control in the laboratory process, analyze the data, store the data, and then the reporting happens. So let me just look at, show you the current scenario in India. So it is not all that glorious if you look at the number of BRCA labs that we have. So there are 18 labs, of which 3 are in-house labs, and there are 15 commercial labs. So the red ones are the commercial labs, which are distributed far apart. This part of the country is not represented at all. And these are hospital labs, 3 of them, one in Delhi, one in Mumbai, and one in Bangalore. So the average monthly testing is about 500 only, considering that the incidence of breast cancer and other cancers is quite high. So this is my hospital's experience. So this is HBOC cases determined basis the family history and the So these are the HBOC. Can you hear me now?
It's okay. It's okay.
Okay. So these are the 78 cases deemed to be hereditary breast ovarian cancers. They were tested, and we found that about 63% of them were negative, 27% were positive, and we had a VUS of 10%. So that with the existing platforms, you do get that high VUS, but if you were to do a myriad, it may be much lesser. So this is what we found in our patients. So most of them were BRCA1s, and the rest were all very few, but we did get ATM, PALB2, MLH1, RAD, and CHEK2 mutations as well. So all these cases did undergo pre and post-test genetic counseling. We are fortunate to have a molecular oncologist and a genetic counseling person in our facility, and I must acknowledge his help in preparing these slides. Dr. Amit Verma is the person. So just to give you an idea as to what kind of load do we see as far as breast cancer is concerned, in 2015, it was about 155,000, and we're close to 170,000 as of now, new cases a year. 5-year survival rates in all patients, if you look at across the board, it's about 60%. But when it comes to stage 4, it is about 22%. You just mentioned that about 60% of your patients are locally advanced or metastatic, and that is pretty much similar to what we see in our country also. 72 to 84% of all our patients have a HER2 negative, but 31% are reported as triple negative, which is much higher than what it is in the West. 5 to 30% of patients with breast cancer or ovarian cancer harbor germline BRCA mutations. So this is the population that we should be looking at targeting with the newer agents to improve outcomes. So the Asian data by and large suggests that about 11 to 30% of patients who have who are triple negative are BRCA mutants. So if you look at this, if you just focus on this, this is the triple negative group. And we all know that triple negative breast cancer has had dismal results and has not shown significant progress in terms of survival in the past many years. So what happens, like I've already told you, there is a definite unmet need in metastatic breast cancers. There is no doubt about it. And the 5-year survival in metastatic breast cancer is only about 22%. So this is a huge area that we need to focus on. This has to improve. In phase 3 studies with metastatic breast cancer, the progression-free survival with a single agent, the eribulin, capecitabine, or vinorelbine, was approximately 4 months. With eribulin monotherapy in an Indian study, the reported overall survival was about 6.2 months. And the chemotherapeutic options we know has got limited activity. They also have poor toxicity and tolerability profiles, especially in this metastatic breast cancer situation. So when you look forward, it is very encouraging to see that olaparib, offers a new, which is the PARP inhibitor. It offers a new targeted treatment option for germline BRCA mutation patients with HER2 negative metastatic breast cancer. So that is where we need a lot of focus on, and with these new molecules, I'm sure we will see more improvements, as we have seen in HER2 positive, hormone receptor positive, HER2 negative metastatic breast cancers. The options are so many, and we are seeing that breast cancer has become more like a chronic disease in the hormone receptor positive groups. So we know that in 1977, we started off with tamoxifen. We saw a brilliant impact on the survival. And then in the late 90s, you had the aromatase inhibitors coming in. And then you had fulvestrant coming in 2002. Add to it the mTOR inhibitor, everolimus. And now you have these three CDK4/6 inhibitors, which have definitely added to disease-free survival and tending to overall survival also. So look at the chemotherapy for metastatic breast cancer. We know however much we tried, this was the initial therapy, there was a relapse, and then a first-line chemo was started here. Effect lasted 12 weeks. Again, there was progress. Second-line chemo started. Then again, just about 9 weeks, it could hold up. A third-line chemo, just 4 weeks. So, you know, we are not gained much in terms of chemotherapy alone, in terms of progression in metastatic breast cancer. Now come to triple-negative breast cancer. This is advanced triple-negative breast cancer. So once you know that you have a situation like this is the time to counsel the patient for genetic testing. And if BRCA mutation status testing should be discussed at this time. And then you can decide on single agent chemotherapy. If she was previously untreated with taxanes or anthracyclines, you can add that here. But if after single agent chemotherapy, and if she's been treated with anthracyclines or taxanes earlier, you have exhausted that option. So now you have to do a BRCA mutation. So if there is a BRCA mutation, you should consider carboplatin and, of course, PARP inhibitors. If it is a wild type, there is no mutation, you have these options, which is capecitabine, eribulin, and vinorelbine. So these are the various options, which I've already just told you that in patients with metastatic triple-negative breast cancer, but we are looking at whether we can add more value to whatever is already there. So let me now come to PARP inhibitors, because we are talking about DNA repair gene. So we do know that BRCA1 and 2 are tumor suppressor genes. So the functional BRCA protein is very important to regulate cell growth and to prevent abnormal division, because that is what is going to lead to tumor development. So the BRCA protein is expressed in various tissues, and it reaches the highest level of expression in the S phase. And that is where the DNA sequencing repair happens. The double strand break repair happens. So you know that in BRCA1 and 2 mutation carriers, if you talk about tumorigenesis, it follows a 2-hit hypothesis. The first hit is on the is due to an inherited mutation. So that is the germline bit of it, which is on one BRCA allele. And the second hit is because there is an inactivation of the second wild type allele in the protein. So women who have an inherited mutation of BRCA1, we know they have an increased risk of breast and ovarian cancers. So we do know that BRCA1 and BRCA2 mutations account for about 20 to 25% of all hereditary breast cancers, and for about 5 to 10% of all breast cancers, irrespective of family history. Approximately 46% of BRCA1 mutation carriers and 52% of BRCA2 mutation carriers will be diagnosed with breast cancer at some point in time. So this is very, very important to understand. So now tumors without a functional BRCA gene requires the PARP enzyme to repair the DNA damage. So once the DNA damage is repaired, it can continue to multiply. And that is where we need to step in. We need to inhibit this PARP enzyme so that the DNA repair cannot happen And this is the potential target for cancer therapy. So this is the Olympiad trial. This is a phase 3 study which investigated olaparib versus the physician treatment choice of chemotherapy in germline BRCA mutation. So this is TNBC or HER2 negative. It could be hormone positive, less than or equal to 2 cycles of 2 lines of chemotherapy for metastatic breast cancer. A previous treatment with anthracyclines, anthracyclines and taxane, either in the adjuvant setting or in the metastatic setting. And if patients have received platinum therapy, there should be no evidence of disease progression during treatment in the advanced setting. And at least 12 months since the neoadjuvant or adjuvant treatment should have elapsed before randomization happened. So this is how they were randomized: olaparib 300 milligrams orally twice a day. Primary endpoint being progression-free survival, and of course, the secondary endpoints being overall survival and a second progression, and of course, quality of life as well. So what has been seen in the various groups is that olaparib does have the potential to prolong chemotherapy-free interval. That is very, very important to the patient. So there is a progression-free survival which is reported in Indian population of 3.5, but if you look at the overall thing, you are seeing about a 5.2-month difference in a second progression, a 4.2-month difference in the first progression. If you look at the adverse events, you will see that it does not have a very poor adverse event profile. Grade 1 and 2 in about 60%, grade 3 happening in 36%, but it compares well in comparison to chemotherapy. So nausea, vomiting, and fatigue were the most common the adverse events reported in the olaparib arm. So additionally, if you look at those who had to have dose interruptions, about 35% of patients on olaparib did require dose interruptions because of the adverse events, and 25% needed dose reduction as well. A very small percentage, about 5% of patients discontinued treatment in this trial. So 13% of patients were still ongoing treatment at the data cutoff. So 87% had discontinued the treatment, and the reason was, of course, there was objective disease progression. So if you look at the quality of life, it favored patients with olaparib, especially in a metastatic situation. I think the quality of life also becomes very, very important. So there has to be clinically meaningful benefit for patients. Only then that treatment is useful. And that is what has been seen with olaparib, where the global quality of life is in favor of those treated with olaparib. So time to deterioration of global quality of life also favored patients treated with olaparib as compared to chemotherapy. So the overall conclusions for Olympiad is that there is a 42% reduction in disease progression. There is a 49% reduction in risk of death when olaparib is administered as first line in metastatic breast cancer over chemotherapy. So that is very important, that you have to use olaparib instead of chemotherapy to get that kind of benefit. It is generally well tolerated, as I told you, and it has nothing to compare with the chemotherapy arm. And it is consistent with the known safety profile, which has been studied extensively with ovarian cancer. So the olaparib we do have a positive profile of olaparib in germline BRCA mutations. It's an oral therapy, which is easy and it is convenient for the patient. So this has demonstrated that olaparib definitely has got more use with cancers other than ovarian cancer. And in September of 2020, the NCCN guidelines does show that olaparib is recommended in BRCA mutated metastatic breast cancer, who's got a germline mutation. So I'll just leave you with this slide, which is the Olympiad trial, where adjuvant olaparib has been looked at in BRCA mutated HER2 negative breast cancer. And this is where they stop treatment. The primary endpoint is, of course, invasive disease-free survival with the usual secondary endpoints of overall survival, distant-free survival, incidence of new cancers, and quality of life. So some very interesting things coming out of the interim results. I mean, very interesting interim results coming out of this trial, which I would encourage you to look at. So let me just show you a couple of cases who were treated in our center. This is a patient. This is a comprehensive genomic profiling was done, and a BRCA2 alteration was found in metastatic breast cancer. So this is a 55-year-old lady who had history of breast cancer. She's ER positive, PR negative, and HER2 negative metastatic breast cancer. This was characterized by FISH. So this is where we started. This is where she had the metastasis. So she was started with paclitaxel and bevacizumab. So she had radiation to the metastatic site, and then she was given into the bone, and then she was started on everolimus and exemestane. Then there was from here to here, which is about 4 months here, 4 weeks here, and then she went on to everolimus and letrozole. Then again, there was progression, started again on fulvestrant, boparcilib, and then put on eribulin. Again, another round of chemotherapy. And then here at 24 weeks, she received Abraxane. So there is a few weeks that you're getting out of the chemotherapy. And this is when the comprehensive genomic profiling was done, because she was not responding to several lines of chemotherapy, almost 7 lines of chemotherapy done, but there was disease progression. That is when the gene profiling was done, and she was found to have a BRCA2 alteration. And that is when she was given olaparib. And you can see that she had a pretty decent response in the sense that she went from 24 to 36 weeks on olaparib. And if you see, there was a positive response and there was some long-term benefit from olaparib, but this was followed by disease progression in liver and lung with bone mets. So if you see, that is what was at baseline. This was pre-treatment. You could see this disease. After 2 months of olaparib, it has almost completely disappeared. But at 10 months, of course, it has come back. But then, even after 36 weeks, the treatment was continued. So she had radiation to painful bone mets, olaparib and carboplatin and paclitaxel was done. Was given, and then she was put on tamoxifen also because she was hormone receptor sensitive. And at this point, when progression was, there was still more progression, treatment was stopped. So why there was resistance? So this is what was, this is what was inferred from this fact that she was progressing now despite olaparib. So there is something called a BRCA2 reverse mutation. And this was detected both in the tissue as well as liquid biopsies. And this is what is possibly the explanation as to why the patient stopped responding to olaparib after 36 weeks. This is the second patient. Again, this is a BRCA1 triple negative breast cancer with brain metastasis. 46-year-old, the initial diagnosis said that it was ER positive, 50%, PR negative, HER2 negative, and a Ki67 of 80%, labeled as luminal B. And this is where the treatment started. She was put on doxorubicin AC followed by paclitaxel. And then she had mastectomy and lymphadenectomy. The resected sample was subjected to IHC again. And this time it was found to be triple negative. So after 1 year of treatment, the patient presented with bone pain, and the PET scan and physical examination did confirm relapse. This is her immunohistochemistry. This time, triple negative, Ki67 of 70%, PD-L1 negative, GATA3 and mammoglobin all confirming the diagnosis. So this is how she was treated, olaparib. I'm just finishing the last slide.
Okay. Yeah, time is already time up. Yeah, we can add some more minutes. Okay.
Okay.
You can continue.
Okay.
Thank you.
Okay. So germline mutation assay using 11 gene was done, no mutation was found, and then a comprehensive gene this thing was performed, gene testing was done, and there BRCA1, PIK3CA, and P53 mutations alterations were detected. The microsatellite was stable, but the tumor mutational burden was low. So the patient presented now with brain metastasis and worsening headache, and she had brain lesions as well. As you can see, she had these brain lesions. However, this was an off-label olaparib therapy, which was started on this patient because all the other options had been exhausted. And there was improvement in neurological symptoms after 2 weeks, which is great. And the brain lesions reduced after 8 weeks. So recently, there has been progression in the brain lesions 6 months into ongoing olaparib therapy. But at other sites, at the liver and bone sites, the disease is stable. So there is a lot of encouraging signs, which gives you the thought that olaparib, when it is behaving well in a metastatic situation, after failing several lines of therapy, you do get this feeling that olaparib is possibly going to be of huge benefit in the adjuvant setting. So thank you very much. I'm sure we all have had our share of COVID. I would salute my wonderful healthcare workers across the country and in your country and in the world. I thank them from the bottom of my heart for all that they did for keeping everyone well during COVID and taking care of them during COVID. And I would always want everyone to be safe and healthy. Thank you very much.
Thank you, Dr. Dikita.
Thank you very much.
Yeah. Give applause to Dr. Gita for the informative and very inspiring data and information. For us. And next, it is on purpose for us, for the committee to change. The first speaker was Dr. Gita, and the second one will be Pak Ahmad. I think that he is an expert in the genetic testing, especially in the So what we are going to tell you first, before Pak Ahmad, he will give us the answer of those reports, those that have been presented by Dr. Gita. What is the role of the rationale of BRCA mutation testing? But before that, I just give a short information that BRCA1, BRCA1 and 2 gene is a tumor suppressor gene, as we know, and the BRCA1, BRCA2 protein is the critical role for the DNA repair. So there are some terms that we have to know here, that we are saying that DNA repair pathway. We are on the DNA repair pathway, and we are DNA repair response, damage response. So this is why that we have that. This is mentioned as a homolog recombination defect. So homorecombination defect pathway, it's a lot. It's included in BRCA and RAD51 and the PAP2 and so forth. But today we want to talk about especially in BRCA1, BRCA2 in HRR or homologous recombinant pathway genes. And what we are talking about is DNA damage repair deficiency and how they is going. So time is yours, Dr. Ahmad. Dr. Ahmad, Dr. Ahmad Hussain, hopefully that it will give us more and strengthen our knowledge of molecular. Thank you.
Thank you, Dr. Samuel. Thank you for the selection committee to invite you to share with you some of the recent updates. Thank you, Dr. Gita, to give an overview. And also, I'm being a molecular biologist, is actually quite interested to see that the reversal mutations that recover the length of the protein. So, but what I'm going to do today is, like what Samuel said, is going to describe more of the molecular mechanisms and some of the interpretation. What does it mean to have these genetic alterations? Let me start to share some screen. Dr. Samuel, is it proper for me to share in English, or you want me to say Indonesian?
If we don't mind, I think I will ask Dr. Gita first to present in Indonesia. First, I ask the Dr. Gita first. Dr. Gita, hi,
Yes.
Dr. Gita, you said, yeah. May we present in Bahasa Indonesia?
Go ahead, please go ahead, no problem.
Is it okay?
I will look at his slides. I'm sure I will make something out of the slides.
Okay, thank you. Ya, Mas Ahmad, saya kira bisa kita lanjut dengan bahasa Indonesia karena ini informasi yang perlu kita pelajari bersama sebagai penyokong pengetahuan kita biomolekulernya. Silakan Mas Ahmad.
Okay. Terima kasih. Thank you, Dr. Gita. My slide will be in English, so hopefully you'll follow. Right.
Sure.
So allow me to start. Okay. So the point of today is, have you heard the updates? What is HERD? The HRD is actually homologous recombination defect. And that's actually quite important mechanism. Bagaimana caranya nih? Sorry, maaf nih dokter, jadi ke Inggris lagi. Ya, jadi kita mau bahas mengenai HRD gitu ya. Tapi HRD ini bukan human resources ya, ini bukan mengenai masalah karyawan. Ini HRD ini homologous recombination defect. Gitu. Jadi ini mekanisme terkait obat baru nih. Ini disclaimer saya. Ada beberapa topik, tapi karena tadi dokter Gita sudah menyampaikan banyak hal, hanya 3 saja deh yang mau saya sampaikan. Kalau kita lihat, ini adalah standar terapi di breast cancer ya, terapi hormon, terapi HER2, dan yang paling baru ada namanya anti-PARP ya. Nah, cuma poin di sini saya mau sampaikan adalah kalau kita bicara anti hormon, itu yang diperiksa ekspresi hormon reseptornya. Kalau kita bicara anti HER2, yang diperiksa adalah ekspresi protein HER2-nya. Tapi kalau kita bicara anti PARP, itu bukan PARP-nya yang diperiksa malah, ya kan? Tapi yang diperiksa itu malah BRCA-nya. Betul. Jadi ini sedikit hal yang tidak lazim gitu ya. Nah, makanya ini penting, kita perlu mengetahui mekanismenya. Kenapa anti PARP tapi yang diperiksa kok malah BRCA gitu ya. Nah, jadi ini sedikit mekanisme tentang mutasi. Karena kalau kita bicara DNA damage repair, kita bicara homologous recombination defect, itu kata-kata yang sangat ngawang-ngawang. Kita mulai dari awal dulu, kita jadi basicnya dulu. Jadi tubuh kita itu selalu diserang oleh berbagai macam mutagen. Sumbernya bisa berasal dari eksternal, ya, bisa dari luar, yang namanya external source, atau dia juga dari internal, jadi yang di dalam tubuh kita. Kalau dari luar itu misalnya sinar matahari, asap rokok, dan juga kemoterapi tentu, dan radioterapi itu juga merupakan satu modalitas yang bisa merusak DNA kita, ya kan? Nah, tapi kalau yang namanya internal itu setelah nanti kita makan siang itu pasti ada radikal bebas, pasti itu, nggak mungkin enggak. Dan radikal bebas itu merupakan kontributor juga terhadap mutasi gen. Dan di samping itu, kalaupun kita nggak makan, kita lagi tidur aja gitu ya, itu kan sel kita juga mungkin regenerasi. Dan itu ada kalanya namanya salah ketik. Karena bayangkan, sel kita tuh harus memperbaiki 3 miliar huruf genetik, gitu kan? Makanya biasanya kesalahannya itu sekitar 1/1.000.000. Mungkin kesannya bagus nih, kalau kita punya sekretaris ya di SMF gitu kan, dia bisa ngetik 1 juta huruf, salah satu huruf, itu bagus banget gitu. Tapi kalau untuk ukuran sel itu kurang bagus, karena dia masih bisa miss sekitar 1000 huruf genetik. Makanya di sini penting ada mekanisme perbaikan. Jadi setiap kita ada kerusakan gen perlu diperbaiki. Nah itu ujungnya. Cuma masalahnya karena ada kekeliruan gitu ya, atau bahkan ya sebagian pasien, kita ketahui 10-15% pasien itu sejak lahir itu mekanisme DNA repair-nya sudah rusak sejak lahir. Jadi artinya apa? Ketika orang biasa itu bisa mereparasi DNA dengan sempurna atau sudah mayoritas dia terbaiki, tapi untuk sebagian orang dia tidak mampu, sehingga akhirnya ada akumulasi mutasi, dan itu meningkatkan risiko terjadinya kanker. Jadi itu. Nah, jadi sekarang ada beberapa hal yang mungkin akan kita zoom in ya. Jadi apa sih itu namanya homologous repair recombination, homologous recombination repair. Nah, jadi mungkin ini bayangan dulu secara overall-nya. Kalau misalnya kita lihat inilah DNA itu diserang berbagai macam mutagen, macam-macam. Ada mutagen yang sifatnya seperti radikal bebas, itu seperti ini biasanya. Itu nanti ada glikolase ya, base excision repair biasanya. Dia ada kekeliruan di sini, dibenerin di sini. Ada yang namanya bulky adducts. Ya, pasti kalau misalnya seperti ada bahan-bahan kimia asing gitu ya. Nah, itu akan menyisip dan akan menambahkan gugus organik di sini gitu. Atau kadang-kadang mismatch repair gitu kan, yang mestinya pasangannya seperti G mesti berpasangan dengan C atau A mesti berpasangan dengan T, ini pasangan yang tidak alami gitu kan. Nah, kalau demikian berarti ada juga nih yang namanya double strand break. Double strand break ini menarik. Jadi dia itu kalau kita anggap DNA itu seperti ini ya, seperti rel kereta, seperti pita rel ganda gitu. Itu putusnya itu tus gitu. Jadi relnya itu putus-tus gitu. Nah, kalau misalnya kita lihat dari sisi biologis, masing-masing kerusakan ini itu bukan direparasi oleh satu enzim, bukan. Setiap kerusakan yang berbeda-beda ini punya protein yang berbeda-beda juga, gitu kan. Nah, yang menarik nanti kita bicara BRCA itu kebanyakan di sini, di double strand break, gitu kan. Nah, nanti kita lihat nih pemainnya siapa aja. Oh, maaf. Oke. Lalu sekarang kita mau lihat nih mengenai HRD ya, mengenai HRD, apa yang disebut dengan homologous recombination defect. Nah, jadi kalau misalnya kita bayangkan sekarang kita fokus ke kerusakan yang namanya double strand break. Jadi kalau ini pita ganda kayak rel kereta api gitu ya, itu putus di tengah, tus gitu. Jadi terpisah seperti ini, oke? Nah, untuk menggabungkannya kembali ini ada dua cara dalam sel itu. Oke, yang paling bagus itu yang disebut dengan menggunakan apa yang disebut homologous recombination. Jadi gini, yang namanya pita ganda itu, rel ganda itu harus disambungkan lagi. Nggak boleh didiemin lah istilahnya, karena nanti kereta mau lewat kan. Nah, itu betul-betul disambungkan kembali. Nah, cara yang proper itu tentu adalah ambil petugas kereta api kan dari KAI untuk datang gitu. Nah, yang paling bagus itu adalah dengan homologous recombination. Inilah di sini banyak BRCA berperan. Caranya dia agak rumit karena kalau mau yang serampangan yang istilahnya asal jadi itu yang ini namanya non homologous enjoining gitu kan, ini yang namanya serampangan. Kenapa disebut serampangan? Karena kalau misalnya putusnya itu nggak rata, nggak rata, itu nanti dia pokoknya ngasal aja, yang penting nyambung lah gitu. Nah, kalau mikirnya yang penting nyambung, nanti masalahnya di bagian junctionnya ini itu nanti sekuennya itu nggak sama persis seperti sebelumnya, akan ada yang missing gitu. Itu yang masalah dengan non homologous enjoining. Oke. Nah, tapi kalau yang namanya pakai homologous recombination yang pakai BRCA ini, ketika misalnya ada putus di sini gitu ya, itu sama kompleksnya teman-temannya BRCA dan teman-temannya itu disisik dulu gitu, disisik sehingga nanti ada yang namanya template. Jadi misalnya ini dibuat berjenjang gitu ya putusnya gitu ya, nanti ada semacam enzim yang lain yang berjenjang. Lalu untuk mereparasinya itu nanti apa yang disebut dengan dia ini ada invasion dari sini untuk menggunakan ini yang masih normal. Jadi kan jadi kita punya dua alel gen ya. Ini yang misalnya yang biru dari ayah, yang ini dari ibu gitu kan. Nah, kalau yang rusak yang dari ayah, makanya nanti bagian dari ayah ini, salah satu strand dari ayah ini akan invade ke alelnya ibu. Gitu. Nah, karena alel ibunya masih normal, maka tentu ketika nanti dia akan replikasi masih normal juga. Gitu. Beda sama kalau yang non homologous enjoining, karena dia ngasal aja, gitu kan. Misalnya putusnya pas nggak bersih gitu kan, ya nanti dia nggak peduli kalau misalnya ternyata ada yang missing gitu kan, ada sekuen-sekuen yang missing. Nah, itulah sebabnya kenapa BRCA itu menjadi penting, karena ketika nanti perbaikan, dia akan mengembalikan ke posisi semula dengan sekuen yang bisa dibilang perfect sempurna seperti yang sebelumnya. Tapi kalau ini enggak. Nah, itu kunci yang pertama. Jadi homologous recombination adalah cara BRCA bermain. Oke. Nah, ini makanya penting ketika BRCA tidak bisa melakukan tugasnya dengan baik, akhirnya orang ini akan mengumpulkan mutasi-mutasi sejak lahir itu yang disebut dengan germline mutation dari BRCA. Itu kan makanya lifetime risk mereka tinggi. Oke. Nah, kalau misalnya ini menjadi lama ya dia berisiko menjadi tinggi terkena kanker. Oke. Ini sekali lagi, ini kalau BRCA bermain di sini, kalau nggak punya BRCA nanti dia punya di sini. Nah, itulah sebabnya orang-orang yang nggak punya BRCA, dia karena nggak bisa melakukan ini, dia tergantungnya pakai ini sehingga banyak sekali mutasi. Nah, mutasi-mutasi di sini banyak sekali, sehingga kalau mutasinya berakumulasi, risiko kanker juga akan tinggi. Nah, saya akan tunjukkan ini bagaimana kalau misalnya cara kerja dari perbaikan DNA ini. Mudah-mudahan ini suaranya terdengar. Maaf.
Damage is repaired, a double-strand break can arise. In a healthy cell, this more severe damage.
Jadi kalau tadi dilihat ketika nanti ada kerusakan ya, walaupun kerusakan di sebelah sini, itu kalau cara kerja dari homologous recombination akan seperti ini. Coba kita lihat lagi.
Damage is repaired, a double-strand break can arise. In a healthy cell, this more severe damage can be repaired with the help of homologous recombination. BRCA1 protein binds the loose ends of the DNA and starts to unravel the DNA strands. Using the undamaged DNA strand as a template, the damage is then repaired. Finally, the two strands are separated, leaving both DNA strands error-free.
Ya, jadi itulah keunggulan dari cara homologous recombination, sehingga hasil perbaikannya pun juga masih utuh, gitu ya. Nah, itu tadi cara kerja dari si BRCA. Jadi kalau tadi BRCA dia menggunakan apa disebut dengan homologous recombination repair. Lalu apa nih masalah dengan PARP? Ya, PARP itu sebetulnya bagian dari mesin yang lain, mesin perbaikan DNA, tapi dia fokusnya biasanya ke base excision repair. Jadi kalau misalnya radikal bebas gitu ya dari superoxide anion gitu kan, biasanya dia akan menimbulkan apa disebut dengan NIC, ya dengan apa disebut DNA single strand break. Jadi kalau kita ada pita ganda seperti ini di salah satu pitanya aja, jadi nggak sampai dua-duanya. Kalau ini kan dua-duanya rusak. Nah, ini salah satu aja. Nah, PARP bekerja di sini. Oke. Nah, pertanyaannya kita juga harus tahu, karena saya sekarang jadi dosen, harus ngajarin dulu nih, apa nih yang disebut dengan PARP, gitu, definisi PARP. Jadi PARP itu adalah polyADP ribose polymerase. Jadi enzim PARP itu adalah enzim yang membuat polimer dari apa? Dari ini ADP ribose ini ADP ribose gitu kan. Nah, ini dibuat dibuat polimer. Jadi ini dibuat mata rantai baru gitu kan. Nah, jadi apa yang terjadi ketika misalnya terjadi single strand break karena biasanya dari oksigen radikal bebas gitu ya, habis makan siang gitu kan. Nah, kan muncul nih mutasi di sini. Nah, di salah satu pitanya. Nah, nanti muncul nih PARP ini akan mengikat di sini. Nah, ketika PARP mengikat, dia akan mengeluarkan ini, mensintesa polimer dari ADP ribose ini. Nih, ADP ribose dia akan buat polimernya. Nah, ketika polimer ini terbentuk, ini membuat sinyal teman-temannya yang datang, teman-temannya PARP-nya akan datang bersama. Nah, bisa ada XCC, ada DNA ligase gitu kan, POL-B gitu kan, dia akan datang. Makanya ini penting nih, fungsi dari PARP1, jadi mengeluarkan semacam kayak penanda gitu. Jadi polimer ini tuh sebenarnya penanda ada barang yang harus dibenerin nih gitu. Nah, itulah penting sebagai sinyal. Oke. Nah, siapa saja teman-temannya ini adalah proteinnya nggak perlu diapalin, tapi prinsipnya adalah PARP ini penting untuk mereparasi dengan penuh bantuan ini, dan cara kerjanya dia mensintesa ini polyADP ribose. Nah, kenapa ini penting? Nanti kita bahas, tapi ini untuk memvisualisasinya apa yang terjadi ketika kejadian kerusakan
maintain DNA integrity. Single-strand breaks are repaired through a process called base excision repair, which is mediated by PARP proteins. PARPs recognize and bind to the site of DNA damage on a single-strand break through zinc finger domains. Once bound, PARPs become activated and use NAD+ to synthesize ADP ribose polymers, which are responsible for the recruitment of DNA repair proteins, such as XRCC1, APE1, PNKP, and APTX. Once the protein machinery responsible for DNA repair is recruited, PARPs disassociate from the DNA, allowing for the DNA repair to proceed.
Oke, jadi tadi cara kerjanya ketika nanti PARP itu datang, dia akan mereparasi. Nah, masalahnya apa yang terjadi ketika PARP-nya dihambat? Nah, makanya kan PARP inhibitor dihambat. Nah, ketika PARP inhibitor ini tambahkan ke sini, apa yang terjadi? Si PARP-nya ini pertama dia tentu nggak bisa buat polimer, itu obvious gitu. Tapi yang berikutnya dia juga stuck di situ, dia nggak bisa lepas. Karena untuk dia bisa lepas, kan dia harus membuat polimer dulu. Dan di situ dia juga harus manggil teman-temannya yang lain. Nah, tapi karena teman-temannya juga bisa datang, dia nggak bisa lepas nih. Jadi dia stuck di situ. Jadi bayangkan ada rel kereta api ini, ada petugas datang, tapi petugasnya terus dihambat kerjaannya. Nah, nggak cuma dihambat, tapi dia diikat di rel. Jadi akhirnya apa yang terjadi? Boro-boro petugas ini bisa benerin rel kan? Yang terjadi adalah petugasnya keikat di relnya. Nah, apa yang terjadi? Yang namanya pita ganda ini, Bapak Ibu sekalian, para dokter, ini akhirnya dia jadi stuck. Nah, karena stuck di sini, ini kan padahal rel ini kan jalur kereta api untuk replikasi. Akhirnya apa? Rel kereta apinya menjadi tersumbat, kereta api datang, hancurlah di sini, terjadi kecelakaan yang maha dahsyat. Sehingga itu yang membuat sel ini menjadi sangat defisien. Cuma masalahnya tergantung. Kalau selnya masih normal, artinya BRCA-nya masih normal, dia bisa membebaskan ini. Jadi sumbatan ini dia akan bisa bebasin. Oke. Tapi kalau misalnya sel ini nggak punya BRCA, nah ini akhirnya tetap stuck, dia nggak bisa dibebasin nih, gitu. Nah itu yang menariknya di situ. Jadi pentingnya BRCA itu di situ. Jadi kalau misalnya BRCA-nya masih normal, ini masih bisa oke, gitu. Jadi makanya PARP inhibitor itu tidak begitu bermanfaat kalau BRCA-nya masih normal. Oke. Nah, jadi ini adalah sekitar mekanisme sedikit lebih detail lagi, penting untuk adanya keberadaan BRCA. Nah, makanya di sini apa yang disebut dengan synthetic lethality. Jadi untuk bisa obat ini secara aktif, karena kan kalau kita bicara tumor yang ada BRCA mutasi BRCA itu kan pada sel tumornya itu BRCA 2 alelnya hilang. Makanya kan loss of heterozygosity kan 2 alelnya hilang. Sementara kalau di sel yang lain dia masih heterozigot. Makanya toksisitas dari PARP inhibitor ini mestinya memang tolerable gitu kan? Karena apa? Karena dampak toksiknya itu hanya pada sel tumor di mana alel dari BRCA-nya sudah sama-sama hilang. Oke, makanya di sini ada konsep namanya synthetic lethality, yaitu interaksi genetik antara PARP dan BRCA. Jadi kalau misalnya BRCA-nya masih normal, ya selnya masih bisa survive walaupun dia dihambat oleh PARP. Tapi begitu BRCA-nya memang sudah tidak ada, ya kan, terutama di sel tumornya, bukan di sel yang normalnya, nah berarti tidak terjadi synthetic lethality. Nah, tentu kalau kita bicara terapi tumor, kita ingin memastikan kematiannya spesifik di sel tumornya, bukan di sel normal. Ya, jadi ini konsep synthetic lethality. Oke, nah dari sini saya tidak akan bahas yang lainnya, saya langsung ke bagaimana membahas mengenai hasil tes. Oke, nah jadi katakan pasien sudah diambil darahnya, gitu kan, kalau kita bicara germline testing, gitu kan, jadi sejak lahir orang ini mungkin sudah terkena mutasi gen BRCA, jadi ambil dari darahnya ya, bukan dari tumornya, ambil dari darahnya saja. Karena kita bicara breast cancer, makanya nanti variasi ini maknanya apa, gitu kan? Apakah dia patogenik, apakah dia benign, atau yang terakhir yang bisa menyulitkan yaitu VUS, ya, variant of unknown significant. Nah, ini sekarang saya akan bahas mungkin dapurnya nih, dapur mengenai analisa varian. Jadi bisa ada variasi gitu ya. Ini maknanya apa gitu. Nah, biasanya yang di dapur ini, jadi petugas yang di belakang komputer ini, dia melihat minimal ada berapa hal yang dilihat. Berapa sering varian tersebut ada di populasi. Yang keduanya, punya data fungsionalnya enggak? Jadi apakah mutasi ini pernah dites di laboratorium menggunakan sel misalnya ya. Jadi sel ini sudah didesain untuk menguji varian ini apakah menimbulkan efek. Jadi misalnya kalau kita bicara BRCA itu kan penting untuk DNA repair. Nah, kita bisa punya model di cawan. Kalau DNA repair-nya masih normal, outputnya apa? Itu bisa dibaca dengan teknik biologi molekuler. Atau dari komputasinya. Jadi kita bisa buat model gitu kan. Bentuk proteinnya apakah akan jadi trunkasi, apakah mengubah 3 dimensinya gitu kan, kira-kira fungsi DNA bindingnya apakah berubah gitu, nanti data komputasi dan juga segregasi data. Apa itu segregasi? Jadi ini bicara ketika kita bicara famili yang banyak anak gitu ya, yang saudaranya banyak banget, kan itu nanti ada segregasi. Jadi alel varian tadi itu kan akan tersegregasi kan nggak semua anak sama semua. Ada anak yang mewarisi, ada anak yang nggak mewarisi. Jadi kalau memang varian ini patogenik, apa yang terjadi? Maka setiap anak atau keturunan yang sakit kanker itu selalu punya varian tersebut. Sementara anak yang sehat, dia tidak punya varian tersebut. Jadi ini maksudnya kosegregasi ini penting. Nah, informasi-informasi ini menurut ACMG, American College of Medical Genetics, itu penting untuk dievaluasi. Ya. Jadi sebetulnya yang disebut bioinformatik itu ada 2. Bioinformatik dari bagaimana menyambungkan data sekuen, atau bioinformatik artian explanation-nya, jadi tafsirnya, gitu ya, bagaimana menafsirkannya. Nah, ini yang ada sedikit mungkin kompleksitas ya. Jadi ini adalah aspek-aspek yang dilihat, data populasi. Apa itu data populasi? Jadi kita tahu kanker itu frekuensinya jarang. Karena kita ketahui di Indonesia itu sekitar 40/100.000. Itu nggak nyampe 0,1%. Ya kan? Jadi maksudnya apa? Kalau varian ini ditemukan di populasi manapun, mau di populasi Jepang, di populasi Afrika, di Kaukasia, kalau kita menemukan varian ini, ternyata pernah dilaporkan dimanapun, ternyata frekuensi di atas 1%. Kalau memang seperti itu, kita bisa mengatakan ini likely, very likely karena benign, bahkan mungkin strong benign. Apa? Karena too high for disorder. Jadi kita harus tahu penyakit ini seberapa jarang. Kalau variasi ini ternyata sering, berarti kita tahu ini nggak ada hubungannya. Ya, jadi bisa jadi polimorfisme biasa. Nah, itu yang bisa kita ketahui. Cuma masalahnya begini. Kalau kita nemu varian, lalu kita cek ke database, ke pangkalan data bioinformatik. Nggak ada yang melaporkan nih, di Asia nggak melaporkan, di Kaukasia nggak ada yang melaporkan, dimanapun nggak ada yang melaporkan. Ini menarik. Berarti kalau begitu, makanya di sini scoringnya adalah patogeniknya moderate. Patogenik moderate. Tapi belum final. Jadi ini baru beberapa aspek saja dulu, gitu kan? Jadi ini satu aspek dilihat minimal di data populasinya, ini patogenik yang moderate. Lalu kita lihat lagi. Karena kalau ini kan berarti jarang banget nih, berarti kemungkinan mungkin ada satu hal yang menarik. Lalu kita lihat juga nih, ada komputasi datanya apa enggak? Nah, komputasi data mengatakan apa? Prediksinya apa? Kalau prediksinya ternyata ya ini variasi asam aminonya tidak mengubah fungsi, kemungkinan dia berarti benign. Tapi kalau ternyata nih begitu dia dimodel dengan komputer model, asam amino ini bisa merubah struktur BRCA. BRCA yang tadinya berikatan protein-protein yang lain untuk DNA damage repair, dia nggak bisa berikatan lagi. Nah, kalau seperti itu berarti ada kecenderungan nih, mungkin dia moderate patogenik. Nah, nanti ditambahin nih konsep dari ini, ditambah ini, lalu apalagi nih, data fungsi. Ada nggak laboratorium di dunia ini yang pernah menguji varian ini di laboratorium? Di cawan, gitu kan? Apakah pernah diketahui dia bisa mengubah fungsi transkripsi dari BRCA? Gitu kan? Karena BRCA dia juga memiliki fungsi transkripsi. Nah, fungsi transkripsinya bagaimana? Terkompromi nggak? Bagaimana fungsi dia mereparasi lesi DNA secara in vitro misalnya? Terkompromi nggak? Kalau misalnya iya, berarti patogeniknya makin strong. Nah, ini ditambahin semua. Data segregasinya seperti apa? Ada nggak segregasinya? Kalau ternyata orang sehat pun punya variasi ini, misalnya berarti non-segregation with disease. Berarti di sini ada namanya ke arah strong yang benign, gitu kan? Nah, kita akan bisa mengatakan ini ke arah patogenik atau ke arah benign, itu kalau scoringnya kebanyakan data-datanya fokus ke arah sini, maka nanti ujungnya patogenik. Kalau datanya ngarah ke kiri semua, tidak ada yang ke arah kanan, ini kita bisa mengatakan dia benign. Nah, kalau misalnya sebagian data mengatakan benign, sebagian data mengatakan patogenik, itu namanya VUS. Gitu. Jadi intinya dari situ aja sebenarnya ya. Oke, mana ini saya tadi? Oke. Nah, jadi makanya ini tadi hasil dari masing-masing kotak-kotak ini itu nanti dimasukin ke udah kayak rumusnya gitu ya. Jadi kalau di sini masukin ke sini, ini masukin ke sini, ini masukin ke sini. Nah, inilah salah satu tugas dari tadi di balik mesin itu ada dapurnya itu seperti ini. Kadang-kadang mesin sudah punya algoritmanya sih. Cuma biasanya kalau saya ketika mengevaluasi data NGS, saya cek lagi secara manual, dikonfirmasi lagi. Karena kadang-kadang karena namanya komputer kan tergantung algoritmanya, dia diupdate apa enggak. Kalau algoritmanya nggak diupdate, ya berarti dia nggak bisa miss gitu ya. Oke. Nah, ini contoh di Calgen. Di Calgen ini salah satu varian cukup banyak, gitu kan. Kalau cuma lihat datanya, del nih, del ini kan artinya kan terpotong gitu kan. Berarti apakah jangan-jangan terungkasi? Ternyata kalau dari sisi komputasinya, dia itu preserve the integrity of reading frame. Jadi protein BRCA yang sepanjang ini dia masih bisa panjang ini. Jadi cuma missing satu asam amino aja. Tapi ya itu, ujungnya masih tetap. Jadi kalau misalnya panjangnya katakan 1.500 asam amino, jadi 1.499 asam amino. Cuma tengah situ aja. Nah, jadi reading frame-nya masih utuh. Yang bahaya banget, yang tadi kita sampaikan, ada mutasi yang menimbulkan stop codon. Berarti yang panjangnya segini, dia tinggal separuh. Wah, itu pasti patogenik for sure, seperti itu. Gitu kan? Nah, tapi kalau dilihat lagi nih, ini dari predictive data. Populasi database tidak ada di populasi database. Nah, ini saya bilang Kalau tidak ada di database manapun, dia sudah mulai moderate pathogenic. Kalau ini ke arah benign, karena masih reading frame-nya masih utuh. Sementara cost segregation-nya ada yang membicarakan nggak? Belum ada laporan. Jadi literatur tidak ada yang melaporkan. Data fungsionalnya ada tidak? Tidak ada data fungsional. Nah, berarti kan kalau begitu agak conflicting nih. Dari sisi ini reading frame-nya dia normal, tapi dia emang nggak pernah ketemu di database gitu kan. Nah, inilah yang disebut dengan VUS. Oke, kalau di Calgen rate reduce-nya itu kurang dari 5%. Nah, itu kalau dulu memang Dr. Samuel mungkin ingat sekali, kita sampai berapa ya, 30% gitu ya. Karena apa? Karena memang waktu itu data pangkalan datanya ya, data mengenai database populasinya itu belum sedewasa sekarang, sebelum mature sekarang. Nah, setelah kita update lagi, semuanya kita cek ulang, kebanyakan dari FUS itu sudah downgrade menjadi benign gitu ya. Jadi itu bukan sesuatu yang kita khawatirkan lagi. Oke. Nah, sebetulnya kalau kalau mau belajar di YouTube juga bisa. Ini ada training dari EMQN, jadi laboratorium yang memang rutin untuk melakukan bagaimana scoring dari varian-varian tadi itu sudah ada trainingnya. Inilah contoh-contohnya mereka. Jadi apa yang saya sampaikan, mereka melihat variannya ini gitu kan. Mereka cek dari matriks tadi itu. Apakah dia data-datanya seperti apa gitu kan? Apakah ada data yang menunjukkan ke arah patogenik? Apakah datanya menunjukkan ke arah varian yang benign? Nah, kalau misalnya yang ke arah patogenik nggak ada, ya kan? Nah, berarti kalau gitu ini sudah pasti benign, bukan FUS. Jadi kita bisa mengatakan kepada si pasien dia adalah tidak memiliki varian yang patogenik. Kalau seperti itu ya tidak boleh kasih obat. Dan nanti bagaimana dengan anak keluarganya? Ya tergantung nanti kita lihat family history-nya juga. Ya itu nanti bisa kita bahas mengenai kalau kita bicara mengenai counseling. Oke. Jadi ini adalah gambarannya. Memang kalau yang patogenik itu technically itu dibagi dua, ada yang namanya patogenik atau likely patogenik. Tapi either way sebenarnya ini nggak, kalau secara praktis nggak perlu dibedakan lah, nggak perlu dibedakan. Jadi inilah yang disebut dengan clinically actionable. Jadi kalau misalnya emang dia layak dapat obat, ya kan, ya itu bisa diobatin. Misalnya dalam ini adalah PARP inhibitor. Kalau misalnya dia punya anak, misalnya gitu ya, nah ini kita bisa konseling. Kamu ini kan kita bicara pasien kan, ini pasien udah CMAME, ya pasti dia kena CMAME kan. Tapi karena ditemukan adanya mutasi patogenik, kalau dia memang punya anak, punya saudara kandung, nah ini bisa dikonseling. Karena ada kemungkinan saudara kandungnya atau anak-anaknya memiliki kemungkinan 50% mewarisi mutasi gen yang sama gitu ya. Jadi ini yang bisa kita tindak lanjutin. Tapi kalau misalnya tidak ada, ini berarti no clinical action necessary. Gitu ya. Oke. Tapi memang secara bedah sebetulnya mungkin ada juga sih, apakah ada tindakan bedah yang mungkin tergantung dari data ini. Cuma nanti begini, yang kita perlu ingatkan karena data itu tergantung dari apa yang kita ketahui, ya terutama kalau misalnya VUS gitu ya, itu kita mengetahui VUS itu kan sebetulnya juga dari data yang ada. Kalau misalnya tadi ternyata belum ada yang melaporkan, ya kan? Lalu juga belum ada yang memberikan data fungsional. Saat ini kita bisa mengatakan FUS karena saat ini karena ada sisi time-nya gitu ya. Tapi ada bisa jadi secara formal memang mungkin siapa tahu nih di masa depan ternyata ada data fungsional dan ternyata memang jadi patogenik, misalnya seperti itu gitu kan. Walaupun menurut pemahaman kita sekarang nggak mungkin dia patogenik. Tapi disinilah pentingnya juga untuk memahami kepada pasien apa yang kita interpretasi ini berdasarkan data yang sekarang kita ketahui. Ini terutama berlaku untuk yang kasusnya namanya VUS gitu ya, yang uncertain significance. Oke, ini adalah cara kita ngambil darah ya, karena ini penting. Dan mengenai teknisnya, jadi prinsipnya ada berapa tahapan ya, 3 tahapan utama untuk ngambil dari sampel. Nanti kita adalah proses tes genetiknya sendiri ya, dia ekstraksi DNA, analisa data gitu kan. Lalu nanti klasifikasi untuk interpretasi dan reportnya akan keluar. Oke. Nah, tergantung dari kebutuhan pasien. Kalau yang pasien perlu segera diobatin, apalagi tadi Dokter Gita mengatakan PARP ini kayaknya malah bagus sebagai first line. Jadi kalau pasien misalnya dia betul dia mutasi patogenik BRCA, belum pernah diterapi sama sekali, nah mungkin dia dapat benefit itu. Nah kalau seperti itu kan harus buru-buru, tanda kutip ya, karena pasien kan harus sudah diobatin. Kan mungkin standarnya pakai kemoterapi gitu kan, setelah bedah misalnya, atau misalnya apalah gitu kan. Tapi kalau misalnya emang belum pernah diobati dan dia betul ada kemungkinan besar dia mutasi patogenik, maka labnya harus kasih tahu, ini pasien mau segera diobatin loh, kalau bisa jangan lama-lama, misalnya seperti itu, gitu ya, turnaround time-nya. Oke, mana? Nah, jadi ini prosesnya. Secara prinsip yang paling klasik adalah Sanger. Ya, zaman dulu saya dengan Dr. Samuel pernah kerjasama itu tahun berapa dok ya? Tahun 2010-an 2011 ya dok. Itu kita masih pakai Sanger waktu itu. Nah, tapi sekarang udah pakai next gen method dan untuk kelengkapan memang ada MLPA. Tapi tergantung. Kalau NGS-nya bisa menghitung copy number variation, ini nggak perlu MLPA lagi. Tapi kalau NGS-nya belum mampu untuk melakukan copy number variation secara otomatis, maka perlu dilengkapi dengan MLPA. Jadi memang kita juga perlu tahu spesifikasi dari mesin NGS yang kita gunakan. Ya, ini sedikit technical perbedaan keuntungan dan kerugian dari masing-masing ini ya. Jadi kalau untuk MLPA, dia memang penting untuk melihat copy number. Jadi gen itu kan ada namanya exon gitu, ada bagian-bagiannya, ada subbab lah. Kalau kita bicara buku itu ada babnya, bab 1, bab 2, bab 3, bab 4 itu namanya exon gitu kalau kita bicara dari sisi genom. Nah, kalau MLPA dia bisa ngelihat mestinya kan setiap bab cuma ada satu. Bab 1 ada satu, bab 2 ada satu, bab 3 ada satu, bab 4 ada satu, ya kan? Nah, kalau MLPA itu dia bisa ngelihat, ini bab 4-nya kok jadi 5 kopi misalnya gitu. Padahal kan bab 4 cuma ada 1 kopi. Ya kan? Tapi kalau NGS yang dia baca bukan kopi dari per bab, dia membaca tulisannya. Nah, karena dia baca tulisannya, dia nggak bisa bedain bab 4 itu ada berapa kopi, karena masing-masing bab kan bacaannya sama semua. Gitu kan? Nah, makanya tergantung NGS-nya. Ada NGS yang tidak mampu membedakan copy number bab tadi itu, tapi ada NGS yang memang mampu karena sinyalnya itu ada intensitasnya gitu. Makanya kita harus tahu nih kita pakai NGS yang mana gitu kan. Tapi kalau misalnya memang nggak bisa ya kita harus kombinasi dengan MLPA. Nah, jadi ini saya tadi maksudkan. Jadi katakan ini buku gitu ya. Buku kan ada bab A, bab 1, bab 2, bab 3, bab 4 gitu kan. Nah, yang disebut dengan delesi itu apa? Berarti bab 2-nya hilang. Yang ada bab 1 dan bab 3 lompat gitu kan. Nah, cuma karena NGS itu bacanya dari germline, dia masih bisa ini nih bab 2-nya masih kebaca dari satunya gitu. Sehingga dia susah untuk membedakan. Tapi kalau kita menggunakan MLPA itu bisa. Cuma ternyata sudah ada studi yang melakukan khusus untuk NGS yang mampu ya seperti dari Oncomine platform ini dari Torrent, itu dia bisa kelihatan intensitasnya berbeda. Jadi di sini ternyata ada copy number yang berbeda. Ini berarti ada delesi ini. Mulai dari eksonnya cukup panjang ya. Jadi mulai dari ekson 23 sampai 27 tuh dia missing gitu kan. Nah, ini berarti bahaya. Berarti di sini adalah patogeni. Dan cukup spesifik juga. Jadi ini dengan MLPA, ini dengan NGS yang mampu melakukan copy number variation, sama-sama positif, sama-sama negatif, tidak ada yang false positif maupun yang false negatif. Oke, ini contoh dari lab sebelah ya, dari MedGenome di India. Itu mudah dibaca sebetulnya ya. Jadi di sini misalnya contoh ditemukan patogenik mutasi, ya kausatif gitu kan. Tesnya seperti apa? Lalu di sini disebutkan alamat mutasinya di mana gitu kan. Ini yang bisa dilakukan di MedGenome ya. Dan hasilnya bahkan juga sampai ke interpretasinya juga gitu ya. Nah, di sini bagusnya laboratorium di MedGenome ini mereka juga kalau diperlukan akan bersedia untuk membantu. Jadi ketika nanti dokter menghadapi pasien gitu kan, maknanya apa nih dok? Gitu kan, ada mutasi. Nah, mereka biasanya siap untuk backup di situ. Nah, itu kalau di MedGenome. Oke. Nah, ini kalau di Calgen, di mana saya juga masih sebagai konsultannya, walaupun saya sudah bukan karyawan KLB lagi, tapi masih difungsikan sebagai konsultan. Nah, di sini juga mirip ya. Jadi di sini cara bacanya sudah ada beberapa hal yang bisa dilihat, misalnya identitas dari pasiennya, gitu kan. Lalu di sini disebutkan ada nggak nih patogenik mutasinya. Jadi kalau misalnya ada, nanti ada contohnya apa. Tapi kalau misalnya nggak ada, ya berarti nggak ada. Sebutkan di sini. Di sini ada panduan umum. Ada panduan umum yang untuk mengartikannya. Karena kadang-kadang yang berbahaya adalah tidak ditemukan mutasi nih, gitu kan. Nanti kalau ini dilakukan pada orang saudara dari si pasien tersebut, mereka akan menganggap happy gitu kan. Berarti saya nggak akan kena kanker payudara gitu. Bukan seperti itu. Jadi wanita itu punya baseline lifetime risk itu 12% gitu ya. Nah, tapi kalau dia punya sejarah keluarga itu bisa naik sampai 2 kali lipat. Cuma kalau dia nanti tetap positif, nah baru tuh nanti lipatnya lebih tinggi lagi, bisa 6 sampai 8 kali lipat gitu. Jadi makanya penting untuk melihat bagaimana ini dilakukan. Tapi nggak masalah kalau di Indonesia dan hasil dari Calgen, saya masih bisa bantu untuk mengarahkan ini maknanya apa buat keluarga pasien terutama gitu ya. Nah, inilah contohnya, misalnya kalau ada mutasi terdeteksi, dan di sini disebutkan alamatnya di mana, di kodonnya sebelah mana, gitu kan, dan ini berarti bisa diobatin. Kalau memang pasien ini diperiksa untuk diobati. Gitu. Nah, ini yang tadi saya sebutkan, jadi kalau populasi general, semua wanita itu punya risikonya secara umum 12%. 1 dari 8 ketika mereka mencapai umur 70 tahun, itu 1 di antara mereka akan terkena kanker payudara. Sementara kalau kita bicara ovarian cancer, itu lebih kecil lagi ya, 1,3%. Tapi begitu dia membawa mutasi BRCA2, itu tinggi sekali, bahkan mungkin hampir 40 kali lipat gitu ya. Nah, ini menunjukkan apa yang disebut dengan actionable. Jadi di sini ada risk prevention yang memang sangat detail gitu kan. Misalnya mereka juga harus cek lebih rutin, lebih mudah untuk general check up-nya gitu ya. Oke. Nah, kalau misalnya ini sedikit lihat frekuensi seberapa sering sih mutasi BRCA. Jadi kalau kita lihat any disease, jadi breast cancer secara umum gitu kan. Nah, kalau kita fokus ke sini, prevalensinya berapa banyak sih ada mutasi BRCA2? Sekitar mungkin 10%. Ya, angka ini bisa sedikit naik kalau kita bicara TNBC, triple negative breast cancer. Dia bisa sampai 20-25% gitu ya. Tapi secara umum, any breast cancer tergantung seberapa sering center itu melakukannya, sekitar antara 1,6-10,7%. Nah, kalau di Calgen berapa? Ini di Calgen saya kemarin lihat intip sedikit datanya gitu ya. Antara 2014 sampai 2021 per Maret kemarin gitu ya, ditemukan 15 dari 241 pasien sekitar 6%. Dan dari 6% ini mayoritas adalah BRCA2. Jadi kebalikan dari India. Jadi India itu tadi kan mayoritasnya malah BRCA1. Tapi kalau kita ini mayoritas BRCA2. Dan ini cocok di Asia Tenggara. Jadi kalau kita bicara Asia Tenggara, Singapura, Malaysia, Thailand gitu kan. Kita ini somehow banyakkan ke BRCA2, bukan ke BRCA1 gitu. Nah, tapi ini sekali lagi per dokter bisa beda ya. Saya ingat kemarin sekitar 50-an pasien, lumayan banyak nih Dr. Samuel. Mungkin Dr. Samuel juga kalau bisa ada waktu bisa share juga nih dengan kriteria semanda beliau gitu ya. Ini lebih tinggi daripada yang di sini. Kalau kita overall 6% gitu ya. Tapi kalau pasien-pasien beliau itu bisa lebih. Nah, saya nanti kalau misalnya didiskusikan nggak tahu nih rahasianya semanda seperti apa gitu ya. Oke. Jadi take home message-nya intinya adalah memang HRD, homologous recombination deficient itu menjadi isu penting ketika kita mau memberikan obat olaparib atau PARP inhibitor gitu ya. Jadi yang diperiksa bukan PARP-nya, yang diperiksa adalah BRCA-nya gitu ya. Dan informasi ini penting kalau misalnya kita bicara pasien kanker yang diperiksa, berarti ini untuk pengobatan. Kalau misalnya memang pasien ini punya anak atau dia punya saudara kandung, nah itu mungkin bisa dipertimbangkan untuk diperiksa juga. Karena mereka saudara-saudara kandungnya, anak-anaknya punya probabilitas sekitar 50% untuk mewarisi mutasi yang sama. Baik, demikian seperti itu, Dr. Samuel. Ini saya kok nggak dihentikan ya, takutnya ini udah lewat ini. Mohon maaf kalau misalnya kelamaan. Monggo silakan.
Terima kasih Mas Ahmad, Mas Ahmad Rusdan dengan presentasinya yang begitu bagus dan begitu informatif, dan memberikan kita mengenal biomolekuler atau dasar-dasar dari pemeriksaan genetik lebih kokoh. Dan ini mungkin nanti bisa masuk ke dalam acara yang berikutnya, dalam diskusi, panel diskusi. Kami akan mengundang 2 panel diskusi, Dr. Sonar dan Dr. Pandan. So for the further discussion, we'll have our panelists, Dr. Sonar Sonipanigoro, specialist oncology consultant, and Dr. Ramadan, surgical oncology consultant, to share with us with our discussion, panel discussion. I think we can talk in English both and bahasa Indonesia. Silakan, saya buka, silakan. Mungkin Dr. Sonar.
Okay, thank you, Dr. Samuel. Nice to meet you, Dr. Gita and Pak Ahmad. Nice to meet you again. And after several meeting in the past several years ago, I don't know what should I discuss in this session, because the 2 speakers is already described about the theory, also the practical. But I want to share a small, not a small, but not experience, but it's expression of my confusion as a surgical oncologist. I'm sorry, I want to share my slide. but I'm sorry, Dr. Gita, I will express in Indonesia because I want to, have a, not declare, but several, the very important thing that I have to discuss with my colleague, especially as a surgical oncologist. It is the, can you show my slide? Okay, it is the current situation. So I think, as we know, all of the medicine right now, to my opinion, is like a reactive medicine. In surgical of view, as maybe Prof. Chakra, or is hopeless surgery. If we have no such imaging in maybe 20 or 50 years ago, sometimes if we do surgery, we are hopeless surgery because we don't know, whoop, well, I have to stop the surgery because there are several difficulties in the surgery. Right now, we have several improvement in the knowledge, also the technology, but there, if we heard from Pak Ahmad, also Dr. Gita, there are several knowledge that make the clinician, especially me, it's confusing. We have evidence-based medicine. We have now value-based medicine. What should I choose for this patient? To my opinion, in the future, we have to rule this 5P, more personalized. It's when we like Ahmad or Dr. Rijal, we have several biomarkers. It also as a predictive, also as prognostic, maybe prevention, and participatory. Like Dr. Gita said, we have to put all the data in the table and please the patient choose and discuss with the physician. It is not published yet. It is, but the small number research in 2017. So it's 4 years ago. But until now, I'm still confusing about the data. For instance, it is the characteristic. I have a 75 young breast cancer patient. The mean age of the onset is 34 years old. The first degree relation family history about 24%. The molecular type triple negative about 18%. And I try to make one sample of this sample with commercial software like this. Okay. They said there are several mutations, ATM, also BRCA, and so forth. And they also suggest for this patient to have PARP inhibitor. And because this is a commercial software, I do another, I try to do a manual report with open access software like this. And I agree with Pak Ahmad also in my samples about 30% it's more prominent in a BRCA2 mutation. And the result from the other sample is not it is not mutation, it is a wild type. They said, I'm sorry. Can you show the drugs? There's drug, maybe that's not already in the market. It is, I think, it's still in the clinical trial. Jadi apa yang mau saya sampaikan di sini, bahwa ini sebetulnya hasil kebingungan saya selama 4 tahun gitu kan, dengan sampel-sampel itu. Saya nggak berani publikasi, karena semuanya memang, ya tadi, seperti Pak Ahmad katakan, itu sangat dinamis gitu kan. Jadi waktu 2017 dari 75 sampel itu saya periksanya keluar waktu itu, karena saya nggak tahu di sini mana yang kira-kira sudah valid, jadi saya keluar. Dan dari 70 sampel itu dikatakan yang ada mutasi patogen BRCA1/2 itu hanya 10. Tapi kalau kita lihat tadi yang Pak Ahmad katakan pakai reference gen yang terkini, ternyata naik. Jadi hampir 40%, bahkan dari yang BRCA2-nya itu mendominasi ya, banyak sekali gitu, hampir 5 kali lipat dibanding BRCA1-nya. Nah, jadi yang saya ingin sampaikan bahwa ya jelaslah kemajuannya kita harus hadapi, karena tentunya ini akan membawakan kita ke arah kemajuan di masa yang datang. Tetapi saya mohon masukan nih, terutama dari Pak Ahmad secara teknis gitu kan. Kita sebagai klinisi ya menghadapi ini, data itu kan bingung. Tadi saya katakan ada software-software yang berbayar yang memang sudah bisa memandu, tadi seperti tadi juga Pak Ahmad ada software yang lain, tapi tentunya itu berbayar dan juga tetap interpretasinya butuh advice yang baik. Walaupun yang terakhir ini software yang gratisan, tapi juga bingung buat dokternya. Kita kan manual, apalagi kalau nanti kita datanya sudah lebih banyak lagi. Nah, itu yang mungkin menjadi pemicu untuk kita diskusikan lebih seru lagi, karena terus terang saya selama bertahun-tahun ini juga contoh kasus ini belum bisa saya menganalisis apa-apa, dan terutama tadi bagaimana pasien ini akan saya apakan gitu kan. Ya sekarang ditangani dengan standar terapi saja, tapi tidak ada tindak lanjut seperti saya katakan Pak Ahmad tadi, ada action tertentu untuk menanggulanginya. Demikian Dr. Samuel, terima kasih banyak.
Ya, terima kasih Dr. Sonar. Mungkin pengalaman Dr. Sonar itu juga persis yang kami alami. Saya, Dr. Uco, Profesor Wisma Arif, Dr. Ramadan juga sama. Kita juga menunda publikasi dengan push yang tinggi, dan awal pertemuan di Asia, kamilah yang pertama berakatu di RCA itu dan nggak dipercaya di luar. Dan kita juga takut publikasi, sehingga ini mungkin Pak Ahmad bisa ngasih pencerahan, karena waktu itu memang dari perkembangan seperti Dr. Sonar sebutkan tadi, teknologinya berkembang begitu pesat. Silakan.
Saya udah coba sih Dr. Samuel, langsung di reject. Saya udah coba publish, di reject langsung ya, dalam 24 jam.
Ya, benar. Jangan takut di reject. Dulu kita bilang BAC itu, dan pertama ngajukan push paling banyak di reject juga. Ternyata semua juga banyak push. Mungkin Pak Ahmad bisa membantu menjawab persoalan ini. Silakan Pak Ahmad.
Dr. Sam, saya boleh ngomong dikit?
Oh, silakan Dr. Ramadan. Dr. Ramadan mau bicara.
Thank you.
Silakan Dr. Ramadan.
Thank you. Same with Dr. Sonar. I think I'm confused. It's the right or not. 5 years ago in Portugal, in advanced breast cancer, in the back of the forum, I discussed with the speakers, and what he said, this drug is from hero to zero and to from zero to hero and back to zero again. That he said in back of the meeting. I see that Dr. Grita, I know that he confused when he meet with the patient with triple negative breast cancer. What he did is he make testing, PD-L1 testing, and then BRCA1 testing, only for determine what the drug after the treatment. And maybe for the next, we will make more testing for triple negative breast cancer or luminal up, luminal B, and so on. And I think it's many puzzle. We don't meet now, according our confusion. Thank you. Maybe Dr. Samuel will. And I always meet the views I always make the testing, but I don't make decision. It's difficult to make decision for the patient with testing. Thank you.
Ya, terima kasih Dr. Ramadan. Mungkin Dr. Ramadan memang selalu tadi menyampaikan from zero to hero ya dalam treatment. Mungkin nanti kita bisa bahas bersama tentang Olympiad ini. Itu memang itu PARP inhibitor itu mungkin Pak Ahmad yang bisa jelasin. Dan kebetulan banyak berangkat tuh ya, itu pada panjang region yang fungsional pada exon 11 itu ternyata kurang respons ya kepada BRCA1. Itu Pak Ahmad yang jelasin. Tapi pengobatan ini memang terbukti pada kasus-kasus banyak di ovarian cancer. Jadi ovarian tadi seperti saya sebutkan itu di tingkat protein kan tentunya di somatiknya. Memang mereka juga nyoba somatik test. Jadi kalau ada Dr. Ramadan confused juga tentang genetik test, silakan Pak Ahmad. Jadi antara tadi yang hasilnya itu from zero to hero, from hero to zero tadi, bahkan bagaimana after the treatment tadi Dr. Ramadan juga menjelaskan, dan Dr. Sonar juga cukup menjadi masalah, sehingga hari ini sebetulnya kita mau launching ya, mau menyampaikan bagaimana gerakan kita ke genetik test. Tapi coba kita selesaikan dulu masalah di dapur kita. Silakan Pak Ahmad.
Thank you, Dr. Samuel. I would like to give a heads up to
bahasa
Dr.
Inggris juga, bahasa Indonesia campur aja.
Okay.
Yeah, so that Dr. Gita will join with us, will share with us her experience that our colleagues from the surgical oncologists, when we try to follow about this germline mutation test for BRCA, we got some kind of confusion. First is because the result is like what we have refused, and Dr. Sonar tried to use the computational, the bioinformatics to the open resource for getting the test, but still some confusion, and the confusion leads us to a reality, and I find so far I think Pak Ahmad will give our solution that our confusion is really a surgical confusion. I think it's very real and very factual, and we can say that we now know that our result is not incorrect, it's correct, and that is why we want to strengthen our technology. And for this, I'd like you both give some experience of our problem. Silakan Mas Ahmad.
Dr. Samuel. Dr. Gita, allow me to start first. Basically, there are two main questions that are addressed by our panelists. One is regarding the computational issues, how to interpret the variance. I guess I'm going to explain it in what we know about the databases. But I would like to ask you to explain regarding this from hero to zero and back to hero again, if it's possible, regarding this olaparib study, because we know some of the result is a bit, it doesn't extend overall survival, but it seems to be a practice changing in ovarian cancer. But I wish you would elaborate on that hero to zero issue. But allow me to start with the issue with the computational. Dr. Sonar dan Dr. Samuel, ya memang saya bisa merasakan karena memang gimana ya, untuk bisa mengapresiasi itu sebetulnya ada dua hal yang kita perlu petakan dulu. Jadi kalau kita bicara genetik itu kan sebetulnya hanya sekuen. Jadi di database itu ada namanya sekuen tanda kutip normal. Lalu kita akan bandingkan sekuen yang kita periksa ke yang normal tadi itu. Nah, cuma kan pertanyaannya normal itu siapa kan gitu kan. Nah, tapi oke lah. Ya udah kita sepakati normal ini wild type tadi itu ya sebagai wild. Cuma ini masalahnya genomnya siapa juga ini gitu kan. Buas ya, wild soalnya kan gitu. Nah, jadi pertanyaannya adalah ketika kita berbeda itu maknanya apa? Jadi komputasi itu ada dua, Dr. Sonar. There are two. Yang rumit, informatik yang rumit, ya kenapa harus pakai coding, kenapa harus pakai high computing software, itu untuk menggabung-gabungkan. Jadi ketika NGS kan dia misalnya panjangnya sekian, itu kan bacanya kan nggak utuh sekian panjang kan dok. yang dibaca itu pecahan-pecahannya. Jadi dari sini ke sini, sini ke sini, sini ke sini, sini ke sini, sini ke sini. Nah, jadi ada komputasi yang sangat rumit supaya masukin puzzle-nya jangan keliru. Jadi yang harusnya di tengah ya di tengah, yang harusnya di pinggir pojok sini di pojok sini, yang di pojok sini pojok sini. Nah, itulah kerumitan dari komputasinya, gitu kan. Tapi komputasi itu sudah standar sekarang. Jadi apapun NGS yang dipakai, apapun mesin yang dipakai, itu nanti ujungnya bacaan dari A sampai Z pasti sama. Gitu. Jadi kita nggak khawatir itu sekarang. Jadi dari sisi technical komputasi itu nggak jadi isu. Tapi sekarang yang mungkin lebih praktikal adalah yang tadi Dr. Sana katakan, oke, semua mesin menemukan varian yang sama. Ya kan? Di posisi kodon sekian, ada perubahan dari A ke T, dan itu mungkin ada in-frame deletion misalnya gitu. Itu biasanya seperti itu bacaan ininya. Nah, berarti memang sekarang kita harus belajar apa yang disebut dengan aspek dari variasi genetik. Jadi aspek dari variasi genetik ini kita lihat tadi dari minimal 4 hal. Dari frekuensi di populasi, dari hasil fungsinya, lalu dari segregasinya, data familial hereditary inheritance-nya, dan juga mungkin dari computing modeling-nya. Jadi dari 3 dimensi struktur dari itunya. Jadi 4 hal ini yang harus back in mind harus kita ikuti. Nah, biasanya yang berbayar itu mereka sudah lakukan itu semua buat kita. Gitu kan? Nah, cuma yang jadi pertanyaan yang menarik adalah apakah semua yang berbayar itu memiliki hasil yang sama? Gitu. Nah, makanya kalau biasanya saya baseline pertama itu saya ke ClinVar dulu, Dok. So, I go to ClinVar first, dan itu nanti akan dilihat. Nanti kalau ClinVar mengatakan benign atau pathogenic, itu biasanya sudah ijma. Nah, ini kalau kita bahasa ulama itu semua expert sudah setuju. Ini udah patogenik. Karena mereka mengatakan dari berbagai laboratorium. Jadi kalau kita baca ClinVar itu nanti di bawah tuh ada beberapa laboratorium yang melaporkan, kan ada datanya tuh di bawah itu, dan mereka akan menyampaikan datanya. Kenapa mereka mengatakan patogenik? Nah, itu easy part. Jadi sekarang itu nggak sulit, Dok. Kalau misalnya dokter punya varian dari 78 pasien itu, monggo dimasukkan lagi ke database tadi itu, ClinVar aja itu gratis kok. Gitu kan? Kalau hasilnya patogenik atau benign, itu more or less oke. Nah, tinggal nih dokter lihat dari 78 kasus tadi itu mana yang hasilnya conflicting pathogenicity atau disebutnya variant of unknown significance. Kalau ada keluar seperti itu, berarti nanti harus satu-satu dokter akan mencerna. Kenapa kok ada conflictingnya di situ? Ada di mana? Gitu. Itu yang kita lihat. Kalau zaman sekarang harusnya dari 78 pasien itu yang mungkin masih VUS itu kurang dari 5%, harusnya, kecuali kalau ada satu hal yang sangat berbeda gitu kan. Gitu. Jadi, tapi saya kan nggak punya data dokter sonar gitu ya. Tapi kalau misalnya kita mau kolaborasikan juga, monggo, saya akan bisa bantu lihat gitu kan. Tapi dokter sonar bisa mulai langsung saja dari angka yang dia katakan varian-varian tadi itu, masukkan saja secara manual ke ClinVar itu juga, atau ClinGen sekarang yang lebih sedikit lebih modern lah gitu, ClinGen. Itu mereka sudah cukup bagus kalau menurut saya. Cuma ya tadi begitu hasilnya conflicting gitu kan, nah itu baru menjadi isu. Jadi ini sebetulnya sama juga dengan Dr. Samuel dulu sampai 30% ya Dr. Samuel ya.
Iya, betul.
Ya, tapi akhirnya setelah kita klarifikasi memang ini ternyata di Eropa itu banyak ini sudah ditemukan gitu kan. Memang kita nggak punya database Indonesia sendiri. Jadi ini mungkin saya perlu sharing juga. Kita ini Homo sapien. Oke. Indonesia itu bukan entitas biologis. Jadi kita nggak bisa menamai manusia Indonesia itu nggak ada sebetulnya. Kita dengan orang Laos, dengan Myanmar, dengan Kamboja itu satu rumpun sebetulnya Asia Tenggara, gitu kan? Yang mungkin sedikit beda dengan di Cina ataupun di Kaukasia misalnya. Tapi varian itu kalau misalnya ada sebagai Homo sapien itu sama. Sebabnya kalau kita lihat di populasi manapun, kalau frekuensi lebih dari 1%, itu berarti yang kita temukan di Indonesia itu more likely itu benar gitu. Itu yang harus kita lihat. Itu mungkin Dr. Samuel ya memang kita punya PR ya Dok ya untuk segera mempublikasikan. Cuma masalah saya Dok, sebetulnya lebih sederhana dari itu. Kita sebetulnya cukup untuk melaporkan ininya Dok, status RPR-nya. Itu harus kita cari lagi supaya kita nanti laporannya demografi deskriptifnya bisa lebih detail. Ya, makasih. Dr. Gita, please, your comment about the Hero Zero. Maybe Dr. Gita want to talk, Dr. Samuel?
Yeah, before Dr. Gita will give the comment, because this is on the clinical setting. But before that, I just give some response Pak Ahmad ya. Begini, kita ini sama Pak Ahmad sudah bertahun-tahun mempublish. Ini sudah ada 50 kasus yang baru lagi yang kita amatin dengan NCS. Dan tentunya tadi yang disebut conflicting itu memang benar terjadi. Ya, saya bisa mengerti masalahnya. Akan tetapi tadi variasi genetik dan kita bisa melihat dari ClinVar ya, kita mungkin ikut ClinVar, tapi ada lagi yang baru ClinGene ya. Nah, mungkin nanti setelah publikasi bisa sama-sama, karena di situ publikasi kita mau melihat teknologi di belakang itu, kemajuan itu Pak Ahmad akan ngikutin dari sangar sampai ini, dan juga dalam clinical. Nah, yang saya masukkan in clinical, that what I want to say as Dr. Gita already mentioned, when there is positive, yeah, the germline BRCA test is positive doesn't mean that it always will get a cancer. This is just a risk, yeah. But on the other way around, when this is negative, then that doesn't mean that they will not get any cancer. So then we'll get into the multi-gene panel test. But anyway, I would like Dr. Gita to give the comment of our confusion in Indonesia, because in your country there are so many genetic forum in your country, as many as in South Korea, the most genomic cancer clinics which have been legally or have been professionally established are in India and South Korea. I mean the many numbers of clinics. So can you share your experience?
Thank you so much. So I would like to take up Dr. Sonar's first slide also, which talked about reactive medicine and then evidence-based and value-based medicine. I think eventually, it is the value-based medicine which will stand the test of time. We are not immortal. Whatever we may do, there is no recipe for immortality. So we have to do what is best for the patient in front of you. See, it is not just about giving what is available. We have to assess what that patient can do, what the patient can afford, and not make the patient feel bad if she can't afford a certain treatment. Very important. Because it is true, it's not just true in our country, in the West also, the people I believe about 40 to 50% of Americans are also not insured. And for them, all these treatments that we are talking about is out of reach. So as surgeons, our task is slightly easier. This is what I think. But what gets to me is the fact that while we are talking about de-escalation of treatment, so surgical de-escalation is happening. But if you look at the other side, there is only escalation. So only day before yesterday, I was in a panel discussion when they said, 2-centimeter tumors, HER2 positive or triple negative, give chemotherapy or targeted treatment. So then my question to them was, in a triple negative, 2-centimeter, 1.5 centimeter tumor, what is the chance that there will be complete response? They themselves say 82%. 82% of patients with a 2-centimeter triple negative breast cancer will have complete pathological response. So what am I trying to prove? I don't need that proof, which means 82% of my patients will not fit to do the CREATE-X trial. But I will give, to everybody. So I think that is where, for smaller benefits, it is true that we are treating a large population. So basically, while you are trying to bring down treatment on one side, you're actually over-treating several patients to demonstrate that small benefit. So I have this constant dialogue with my medical oncology colleagues whom I ask, you always talk about disease-free survival. You never talk about overall survival, and disease-free survival could be anywhere in the range of 1 to 3%. And millions of dollars are spent into research and development. And then your zero to hero and hero to zero comes from there. So, bevacizumab, they have been trying so hard to get bevacizumab on the table, but it just refuses to stick. And we all believe that there is, VEGF inhibitor is going to be a big thing. So to my, surgical mind, yes, if there is something that can prevent this new angiogenesis around the tumor, it is going to prevent metastasis. That is what my simple mind would say. But bevacizumab failed to show that impact. And they still don't want to do away with bevacizumab. They still keep bringing it back. There was one statement which said no role for bevacizumab in metastatic breast cancer. But then it finds its way into other cancers, it still stays on. So don't worry, this is not the only drug which has come from hero to zero and then again catapulted into. What happens is, the subgroup where this is effective becomes smaller and smaller and smaller. So you start off with the big group and you realize it is not making an impact there. So that is the time where it is, it's a hero then, projected as a hero. And then you realize, oh gosh, this is not making any impact. And then it falls to the ground. Now what you do is from that data, you start teasing out smaller subgroups. So now you've got a really small subgroup, which is the germline BRCA1 mutation, triple negative breast cancer. So small group. Here it is making an impact. And it is heartbreak for all of us. Triple negative breast cancer, we see our patients failing at 3 years, within 3 years. And then the slide is downhill. We have nothing to arrest the downslide. So I think that is where these drugs will find space. Those people who can afford it. And I would always think that if you are seeing impact in that small subgroup also, bring it in earlier. There is no point trying to, glorify a drug or demean a drug after doing, 7 or 5 or 6 lines of, various lines of treatment and then trying to find space for this. So we have to respect that small subset also. And another statement that Dr. Sonar made was personalized. It is going to become personalized. I can assure you that millions of women have had over-treatment, hormone-sensitive tumors who've been subjected to chemotherapy. But now we know there is a method to find out. Again, not accessible to all, but there is a method. So, we have to deal with different people differently. And that's what personalized medicine is all about. And like I said, we have to cater to that need.
Yeah, thank you. I think I'd like to give comment for Dr. Sonar. He mentioned the 5P. I try to reduce the 3P, the predictive, prognostic, and prevention. I just saw the presentation, the same topic in Singapore. They are telling that we are not knowing about the germline, about the genetic test. We are in the current reactive model. This model is reactive model, meaning that we treat symptomatic management and already metastatic. But we move to reduce the cost, to reduce the symptoms by what so-called proactive model. The goal is proactive. So Dr. Sonar, I think you are right. The 5P maybe can be concluded for the 3P in the middle is proactive. And well, about Dr. Ramadan, I'd like to say that maybe I will ask to Dr. Ahmad that the key word from Dr. Gita is a bottleneck may develop turnaround time. This is the advances of the genomic test. And she is emphasized on the metastatic. So she said that over there, a lot of information on the table, and it will be useful. And in the NCCN guidelines, it also mentioned at the last one that the germline test is used for the treatment, for the targeted treatment. So this is the place. But Dr. Gita today also mentioned, because in India, they both doing on the hereditary forum clinics and also for the treatment. Today presentation are both topics. But anyway, I will ask Pak Ahmad about the BRCA test of the germline and the somatic test. As we know that germline is a tumor suppressor genes, and as a protein, as a DNA repair, and this is more effective. As I mentioned, BRCA1, the ring of domain ring region is longer, and this is
Terus
of
kayaknya
the
dok.
molecule.
Terus Samuel bisa diulang lagi, mohon maaf. Tadi kayak keputus dok.
Begini, kita punya kan BRCA 2 kebanyakan. Nah, dari BRCA 1. Namun demikian, olaparib ini yang PARP inhibitor lebih resisten pada BRCA 1 dan lebih cocok pada kasus CA ovari. Tentunya ini agak nyambung pada CA ovari. Tapi untuk kita itu masuk pemeriksaan genetik ini masuk sebagai entry point untuk nanti strategi targeted terapi. Yang saya tanyakan, apa benar BRCA1 sama BRCA1 dan BRCA itu lebih cocok, lebih sensitif pada BRCA itu untuk PARP inhibitor?
Oh, oke. Ya, terima kasih dok. Ini pertanyaan bagus. Kalau yang saya pahami dok, dari mekanismenya itu baik BRCA1 dan BRCA2 itu mereka penting untuk proses homologous recombination repair. Jadi yang homologous recombination repair, bukan yang non homologous enjoining. Nah, cuma kalau pertanyaannya apakah benar sebetulnya lebih yang BRCA2 mungkin lebih sensitif. Jadi mutasi di BRCA2 itu membuat saya lebih sensitif daripada mutasi di BRCA1. Nah, saya mungkin harus lihat datanya lagi. Kayaknya mereka masih mengelompokkannya jadi satu. Karena secara fungsi molekulernya BRCA1 dan BRCA2 itu satu grup, dok, dalam homologous recombination repair gitu. Tapi kalau misalnya apakah memang ada perbedaan, Allah alam, karena kan memang masalahnya begini dok, pasien ini kan juga jarang ya, artinya tidak sering-sering banget gitu kan. Dari prevalensi di kita aja kan secara umum mungkin sekitar 10% gitu. Nah mungkin kesulitannya untuk membaginya itu kita harus punya banyak sekali pool pasien itu untuk bisa lihat bedanya gitu. Jadi apakah itu karena dari ring domain misalnya, nah itu juga menarik karena ring domain kan bukan di ekson 11 yang panjang gitu kan. Padahal mutasi itu lebih banyak di ekson 11 bukan di ring domain gitu. Jadi untuk tease out perbedaan antar sesama homologous recombination repair genes itu kayaknya akan rumit karena tadi kita mungkin perlu pool yang banyak banget gitu, dan itu mungkin kesulitan dalam uji klinis trial. Walaupun memang sudah Dr. Samuel katakan bisa jadi mungkin yang BRCA2 lebih bagus daripada yang BRCA1. Wallahu alam, saya kurang tahu data itu dok. Jadi saat ini memang masih dikumpulkan bersama. Jadi apakah itu BRCA1 atau BRCA2 selama dia mutasinya patogenik itu indikasinya bisa diberikan. Walaupun memang ternyata kan ya namanya terapi target ya dok, sama seperti Dr. Gita tadi sampaikan ada reversal mutation. Nah ini pertama kali dengar juga ini, karena amazingnya yang tadinya bisa buat trungkasi, begitu ada mutasi tambahan itu direkonstitusi lagi. Jadi yang tadinya truncated dia balik utuh lagi gitu. It's interesting. Ya ini menunjukkan bahwa memang sel yang tidak punya BRCA1 BRCA2 itu kan prone dengan banyak sekali mutasi, sehingga bisa jadi ada mutasi tambahan yang akhirnya merescue fenotipnya tadi itu gitu. Walaupun mestinya memang jarang banget, tapi karena kita ada seleksinya yaitu tekanan dari obat, nah itu akhirnya kita menseleksi varian-varian yang memang bisa menyelamatkan sel itu dari kematian. Jadi ini very classic Darwinian evolution sih menurut saya gitu. Jadi sekali lagi memang untuk yang breast cancer, ini juga yang kedua mengenai kenapa di ovarian itu bagus, yang breast cancer kurang bagus. Allah alam ini juga menarik, artinya pasti di samping BRCA mungkin ada epistasis gen yang lain gitu ya, yang mungkin bermain, karena kita tahu juga profil gen di breast maupun profil gen di ovarian cancer itu nggak selalu sama. Walaupun memang ada arah di mana kita sudah mulai ke tissue agnostik. Jadi kita tidak melihat dari tisunya apa, kita melihat dari biomarkernya apa. Tapi sekali lagi kalau kita lihat dari biomarkernya pun ternyata untuk di breast cancer juga memang sudah sangat sempit ya, yang mungkin yang TNBC dan mungkin ataupun kalau bukan yang TNBC dia yang naif gitu, yang belum pernah di terapi sebelumnya. Itu juga make sense juga karena kalau dia belum pernah di terapi sebelumnya, dia berarti nggak ada perlawanan dok. Tapi kalau dia udah pernah first line, second line, lalu diberikan olaparib untuk berikutnya, ya ini pasien ini dalam tubuhnya sel kanker udah banyak banget varian yang siap untuk melawan apapun gitu kan, dibandingkan kalau dia masih belum terkena terapi yang lain. Itu juga make sense sih dari sisi genetik. Tapi sekali lagi memang kenapa di ovarian cancer itu mereka sampai ke arah somatik, karena memang datanya itu tanda kutip worth it gitu. Karena kan toh pasien kanker ovarium ini kan sedikit. dia nggak sesering apa namanya breast cancer kan. Itu frekuensi di populasi juga nggak sering. Artinya kan paling 1,3% kan lifetime risk-nya. Tapi kalau kita bicara breast cancer itu lifetime risk-nya 12%, jauh banget, dok. Jadi makanya mereka bisa, pokoknya semua ovarian cancer pasien diperiksa regardless family history misalnya gitu. Tapi ya memang tetap menjadi satu pertanyaan menarik, mengapa kok performance dari obatnya itu agak beda nih antara ovarian maupun yang breast. Walaupun yang breast mungkin ada, tapi seperti dokter Gita tadi sampaikan, cupsnya jadi makin sempit gitu. Jadi mungkin tidak semuanya, tapi sangat sempit sekali dan harus diperiksa, dan mungkin harus yang naif, jadi yang first line-nya. Jadi jangan diberikan kalau udah beberapa lines. Gitu. Allah alam, itu kayaknya emang ada kompleksitas itu, dok.
Bang, saya boleh tanya nggak, Bang, ke Dokter Gita?
Boleh, silakan.
Yeah, thank you, Dr. Samuel. I want to ask to Dr. Gita, if we look data in BRCA1 mutation, every country is different. Caucasian different and among Caucasian is different among country. I want to ask to you about, is India have set population mutation? What the most common site mutation in BRCA1 germline? Because what we know is BRCA is very big, and maybe you have data that specific mutation for Indian people is working, and then you go to give the drug for germline mutation. Do you have?
I think that's a very technical question, and I'm sure Dr. Utomo may be able to answer that better. But I think the mutation is the same. I think 180 del, that's a deletion mutation. That's what you see commonly across. Even, and then if you look at the mutations in the Caucasians, also it's the same. I don't think, of course, you do get clustering of various mutations, but otherwise, the mutation is the same. What do you say, Dr. Utomo?
Oh, yes, this is interesting because, as you know, Dr. Gita, for patients with Jewish descent, I think, like you said, I think the DEL 185AG is the way to go because that's called the founder mutations. However, in other populations, then you need lots of data and see whether you see this founder effect mutations. I think the Finnish in Finland and also in other European and Polish, they do have those kind of thing. However, you need to have a good family, clusters in order to find this founder mutation. Especially, it is going to work only in population with a very close ties in their families. They don't marry outside of their families in order to see it. And the nation is made up of that kind of ethnics. But I guess in Indonesia, we are so mixed. Dr. Gita, I don't know in India. Probably India is probably similar. It's highly mixed.
Similar. We are very similar, and we do have these clusters, and they are not BRCA mutations.
I see, right.
So they're not BRCA. So BRCA actually forms only 25% of what we know. So what we don't know is larger. So I think there are other mutations also in action.
That's right. That's right. Yeah, that's why in Indonesia, the only way to find out is we have to have a large number of sequencing, for a large number of patients across different ethnic groups. I mean, in Indonesia, we have also many different ethnic groups. That will be interesting to see the frequency of different hotspots in different sites. Although I myself is a bit pessimistic because tumor suppressor gene, we have basically the entire reading frame is susceptible as anything. Which is different with oncogene. With oncogene, generally you have hotspot mutation, but with tumor suppressor gene, I don't expect to see a single spot unless you do have this founder effect. But like you said, India is also a huge place with a whole different ethnic groups. So this makes the things job a bit more difficult to tease out.
Yes.
Ya, saya kira apa tadi Dr. Ramadan memang begitu. Saya juga dapat laporan BRCA1 mutation pada ovarian cancer itu onsetnya lebih awal itu untuk ASEAN ya. Ini laporan dari laporan dari Asia. Itu disebutkan lebih awal dibandingkan BRCA2 2-3 tahun lebih awal. Dan ternyata yang BRCA1 mutation itu lebih agresif. Sehingga tadi diberikan dokter kita menyampaikan untuk memberi upfront atau first line, saya kira make sense ya. Mungkin yang saya lagi permasalahkan ketika ngomong soal hereditary itu agak beda. Ternyata treatment hereditary harus punya pula kumulatif lifetime risk curve. Sebelum kita dengan kumpulan nanti kita punya secara nasional, kita punya kumulatif lifetime risk, itu yang bisa data itu untuk kita pemeriksa itu untuk memberikan treatment, memutuskan seperti kita sebagai surgical oncologist untuk prophylactic surgery. Mungkin ada Dr. Sonar masih ada yang ingin disampaikan? Mau tanyakan silakan Dr. Sonar.
Cukup, mungkin dari audiens tuh kayaknya banyak.
Oke,
gitu.
ya
Ada
silakan
chat.
kita buka untuk audiens. Silakan Dr. Balta, Ketua Praboy, please. If you might have any questions, we can share with us. You can share with us. Ya, silakan.
Thank you, Dr. Samuel. I want to just only sharing. I have two patients with BRCA mutation, and the first one patient with BRCA mutation with a triple negative breast cancer, and we do the double mastectomy and salpingo-oophorectomy bilateral, and then the younger sister and then the family do the BRCA mutation test, and the result is the younger sister with a BRCA mutation positive, and she had 3 children. 2 child is a boy, and 1 is a woman. And the man, the boy, is two of the son is a male. Have a BRCA mutation, and 1 female is no mutation of the BRCA. And the younger sister checked to the BRCA mutation. Her sisters have a BRCA mutation, and then I do a prophylaxis mastectomy and salpingo-oophorectomy bilateral. And the problem about the first patient, the tumor growth is very fast, and I think that's the situation. If I give the patient olaparib, is it making better? Maybe Dr. Grita can share about my patient, because I think maybe it's now. Should I give the patient with olaparib? Thank you.
Has he been in metastatic?
Yes.
Yes.
She's
Yes.
metastatic.
Okay, Dr.
And
Gita,
has she
please
had?
have your...
Yeah. So she's had, so she's got chemotherapy in the advanced situation also, in the metastatic situation.
Yeah. But she has.
So I think if she is a germline mutation, then you should olaparib is an option. But you have to keep the expectations very real. You can't, and she's young. You're saying that she's young. So this is a young patient with an aggressive triple negative breast cancer with germline mutation. Even with olaparib, after failing or progressing on 2 lines of chemotherapy in the metastatic situation, you can introduce olaparib, but
the patient is 65 years old.
She's 65.
Yes. the patient.
So 65, I wonder how much value it has in terms of even to determine the, germline mutation. It is hard to say. So you can offer it to her, but tell her, the expectations have to be explained to the patient. You can't expect too much out of such a situation. And did you offer her also prophylactic?
The self-finger ovarectomy, we do I try to gamble it. And the result is a positive ovarian cancer.
Okay, you got an ovarian cancer also. But the thing is, I think this is anecdotal, but otherwise, I would reserve these prophylactic surgeries for younger women. Because see, when I say 35 or 37-year-old, it makes more sense because, her lifetime is about, say, it could be up to 80, 85 years, you don't know. So she definitely becomes a candidate for more risk reduction. But at 65, I would be a little hesitant because, at 65, she's already lived 65% of her risk. So at 50 years, you're at 50% risk. At 65, you're at 65% of your risk you've already lived. So you're only reducing about, say, 10% future risk. You're not reducing so much. But at 30, you're reducing close to 50% risk. So, there it makes more sense to offer prophylactic surgeries. So I believe she's got a very aggressive disease. It does explain that it is a very aggressive disease. You did prophylactic oophorectomy and you found disease there also. So I don't know how it is going to be, whether olaparib is going to help. And the fact that the ovary also had disease is possibly it was metastatic and not a primary ovary. Possibly, very hard to say, but I don't think she's got a lot of cancers in the family, and her sister also, I believe you said, has got a BRCA mutation. Her brother has got a BRCA, so it is going to be a tough ride. So it is not easy. These diagnoses are also not easy. What are you doing to the family is something that you must understand. So I don't ever recommend a test without counseling. It does happen in our country, and I'm sure it happens in your country also. To understand what it entails is important. Because I had a patient who was triple negative one side about 12 years ago. 5 years ago, she came back with contralateral triple negative breast cancer. And at that time, 12 years ago, we used to not recommend genetic testing and all that. But this time I said, you go and meet the genetic consultant. He met the consultant. The discussion went ahead on expected lines. She was asked to get a test done, but he explained to her the implications of it and how it would benefit her daughter. And she refused. She said, I don't want to know. So I have a lady who comes from Nepal to me. She was on, she used to come every year. So finally in the 7th year, we caught a small cancer, triple negative breast cancer. She was also advised. Her family is full of cancers: breast, ovary, prostate. She's got 3 daughters. She said, no, I don't want to know. So, we have to draw the line between what we know, what we can do, and what we should do. There is a huge difference. So we have to respect. At the end of the day, you have to play your cards absolutely transparently and listen to what your patient is saying. Because at the end of the day, you are there to serve the patient's needs and not what you know. You may know 10 different things, but it is not possible to apply all those 10 different things to this unsuspecting patient, because we have to respect the patient's wishes. And you have to get to that point of conversation. No point in doing the test and then talking to her, this could have been done and that could have been done. I don't think that's the right time to talk. You have to talk to her when it is the opportune time.
Yeah, thank you, Dr. Gita. I think, as you just mentioned, this is an anecdotal solution. But anyway, in America, it's more. I think it's not rational having contralateral mastectomy based on the contralateral mastectomy only based on the one side on the ipsilateral cancer. And this is quite common, and they didn't perform any genetic test. More and more now in the anecdotal solution in America, it's quite quite a trend. But anyway, I think we'll have I mean in the near future we have our own Indonesian recommendations for our criteria to have the family history and how the management, because today actually we try to launch about the free for genetic test, and we are so scary because those who are negative and they are not yet excluded to be positive, and about the family history, the family value, the ELSA, ethical, legal, social, psychological aspect is so difficult for us to perform in the clinic basis. So now I open for the audience. Please have
I'd just like to make a point. I think you made a very important point. See, we have to generate our own data. It is, we have to generate our own data, develop that conviction. Yeah. Only then can we, because, it's a very interesting, fact that I'll tell you. In the beginning of 2000 and up to about 2003, 2004, the rates of breast conservation in the US were close to 70%. 70%. Yeah. And it came down, and in about 2016, it had gone down to 30%. And the rates of contralateral mastectomies had shot up by 60%, which is huge. And you're absolutely right. It just bases some fear or some whim or without any testing. A lot of women were undergoing contralateral mastectomy because the Angelina Jolie effect, after Angelina Jolie's bilateral prophylactic basis of genetic mutation, there was a surge in the number of mastectomies without a definite mutation being demonstrated.
Yeah, that is why we will have a genetic counseling first to set up the genetic counselors in our country. For those who are interested in this field, we try to develop, and after that we know to set up the criteria. Now it's open for the audience. Mungkin ada yang mau tanya, silakan. Kita ini cukup pelik ini masalahnya, karena sekarang dimanfaatkan untuk targeted therapy jadi genetic test tadi dalam aspek yang kedua sebagai dalam protein. Mungkin tadi Pak Ahmad sudah jelaskan cukup gamblang bagaimana posisinya. Tapi kalau untuk treatment, untuk targeted treatment, memang ini yang dibuka tadi bottleneck-nya karena sudah ada NGS, dan sekarang put it on the table semua informasi biomarker ataupun genetic test untuk pengobatan. Nah, hari ini ada Olympiad yang diperkenalkan untuk kita sebagai DNA bricks, DNA double bricks repair damage atau repair deficiency atau homologous recombinant division atau repair pathway. Nah, silakan yang mau nanya, kita buka untuk pertanyaan terakhir. Kalau tidak ada, mungkin saya minta Dr. Mas Ahmad ngasih komentar lagi. Kalau Mas Ahmad ini sekarang masuk ke best practice juga di dalam penanganan ngasih masukan pada clinician pada dunia ini COVID.
Mas Dr. Samuel, ada beberapa pertanyaan di chat bisa dijawab.
Oke. Ya, kalau begitu untuk ini saya akan akhiri dengan suatu kesimpulan bahwa hari ini telah dipresentasikan oleh tamu kita Dr. Rita yang menyampaikan dua topik, satu tentang sedikit tentang genetic test dan counseling untuk hereditary, dan kedua genetic test untuk penanganan targeted therapy. Itu pertama. Kedua, dari Mas Ahmad tadi sudah menyampaikan kepada kita semua tentang ilmu dasar atau dasar-dasar kita mengenal genetic test supaya kita jangan terjebak tadi, confusion terjadi di mana-mana para klinisi. Tentu bantuan dari saintis, dari biologis, molecular biologis sangat membantu. Terbukti sekarang semua orang mengenal apa namanya PCR. Sangat malu kalau kita sendiri masih bingung, karena ini adalah domainnya dokter juga, artinya itu Mas Ahmad, kita dokter perlu juga belajar banyak dari biologis, mungkin keberadaan Mas Ahmad sangat membantu kita bersama. Dan yang terakhir, kami ucapkan terima kasih dari sponsor dari AstraZeneca yang hari ini mencoba untuk menyumbang pada kita, dan itu tentunya akan kita respons ke depan, kita persiapkan untuk melakukan, kita sudah mengatur program-program untuk suatu course, untuk itu course-nya nggak sekali, 2-3 kali untuk course genetic counseling. Untuk itu saya ucapkan terima kasih dan saya kembalikan kepada panitia. Terima kasih.
Thank you, Dr. Samuel, and all the panelists for the explanation. It's been our pleasure to host this seminar. But before we close the seminar, maybe there's an announcement from Dr. Walter as Chief of Paraboy. Please, Dr. Walter.
Thank you. Saya ingin announcement sedikit bahwa kita akan ada PIT virtual di 26 dan 27 Juni 2021 yang nanti akan di-share di teman-teman Paraboy. Lalu yang kedua ada kegiatan juga di Juli yang nggak kalah menariknya, ini banyak program di mana kerjasama dengan, ini acara internasional sebenarnya, kerjasama dengan YKPI dan tolong mana ya yang mana Bihan ya, ini dengan pembicara internasional yang cukup banyak dan biaya untuk pendaftarannya hanya 300.000. Tolong kepada kawan-kawan atau teman-teman yang ingin mendaftar karena terbatas, bisa dibesarin karena pembicaranya ini penting-penting. Bukan saya loh, saya cuma buka aja ini. Ya itu kira-kira ada dari beberapa negara, dari Amerika, ya. Jadi ini cukup menarik. Mohon jangan dilupakan, ya. Ini acara internasional. Saya berharap bahwa teman-teman kawan-kawan bedah onkologi ikut bisa hadir di acara ini. Mungkin itu saja. And finally, I want to say very thanks to Dr. Gita, Dr. Samuel, Pak Mr. Ahmad Utomo, Dr. Sonar, and Dr. Ramadan. Thank you. Maybe we will meet again in another opportunity, and maybe we must be close to keep in touch. Yes. Thank you very much.
Yes,
Okay,
thank you.
Thank you, Dr. Walter. And last but not least, we have a photo session. For all the participants, please activate or turn on your video because we want to take a picture. Okay, I will count to 3. 1, 2, 3. One more. 1, 2, 3. Okay. For all the participants, thank you. It's been our pleasure to host this seminar. And thank you so much. Stay safe and stay healthy.
Thank you.
Assalamualaikum warahmatullahi
Thank you. Terima kasih.
Oke, izin live para senior.
Terima kasih.
Izin live. Assalamualaikum.
Izin pamit. Waalaikumsalam. Salam.
Yes.